PowerPoint? Do I do that, or how is it?
It's its own desktop.
Okay, so I'll be able to switch over.
Yeah, there's like 3 of them on there. Yeah, the next one's 1 and 2.
I appreciate it.
Yep.
Ken said that the other power, because we like go back to back this time, right? So he said the other
Yeah.
PowerPoint's like on the
Already ready?
Yeah.
Okay, cool. All right, good morning, everyone. Welcome back. It's very, very good to see everybody. Hope everyone had a good night, got some good rest. We are very excited to have another great lineup of presenters today. And I can say that after talking to most of them yesterday evening, they are wonderful people, and I think they're going to have some wonderful presentations. So with that, I'm going to let Jared introduce our first speaker.
Good morning, everyone. I'd like to echo Jalen's welcome. We will kick today off with Professor Zach Buck. Professor Buck is an associate professor at the University of Tennessee College of Law, specializing in health law. His scholarship examines the enforcement of laws that affect health and healthcare in the United States. And today he will be presenting on financing rural healthcare. So if we give him a warm welcome, Professor Zach Buck.
And then if you want to be able to paste, you can wear this one or you can speak into that.
Okay,
It's
cool.
up to you.
I'll try to stay planted.
All right, thank you.
Thanks. All right. Thank you all for being here. And thank you for the introduction, Jared. Thank you to Jalen and Jared for all your work on this and all the law review members. It's really been wonderful. I had a moment to reflect this morning, and this is one of the best parts of my job, is convening with like-minded people and talking about tough problems. I think it gives us hope to meet people who are, especially to meet students who are going out in the world and thinking hard about these issues. Unfortunately, I don't think my talk is going to give you any hope, but but I at least want to recognize that. And it's been tough, for the last couple of years being kind of atomized as a community, and it's nice to be together again. So thanks for all of your work to make it so welcoming. I do most of my work in healthcare regulation. So I write a lot on, what are called finance topics. So healthcare fraud and abuse, white-collar crime, the regulation of Medicare, how we structure laws in an effort, financing laws, reimbursement laws, that we think impact policy. And so I'm interested in kind of the connection between what you might think of are kind of dry, regs in the Medicare statute and why policymakers fight for those regulations and what they actually do in terms of impacting people's lives. So I'm not a rural health scholar, but there are connections in my work or past work and the ideas that we talked about today and yesterday here. So I looked at rural hospitals, and I know Professor Farringer, who follows my talk, is also going to talk about Medicaid expansion and rural hospitals as well. So I'm going to try to set the table and start a larger discussion in my remarks. I'm going to talk about a couple main areas. So a lot of this is going to be observational, sharing data about hospitals that are closing in rural America and why they're closing, the impact on access in rural communities when hospitals close, what I call persistent financial precarity that hospitals find themselves in, policy prescriptions, specifically those from the federal level, and then the takeaways or some of the shortcomings I see with some of the solutions that have been proposed. I also, in previous work, have been critical of hospitals in some ways. I think a piece that I just was published this month is focused on hospitals that sue their patients for unpaid medical bills and that phenomenon that has kind of that trend that is concerning. And so it's kind of an interesting perspective for me to try to focus on the good that hospitals do in communities. So if you sense a snide remark here or there, it's not meant to be too damaging to my thesis on this paper. So rural hospital closures, this is probably not news for anybody in this room, but rural hospitals are closing across the country and have been over the last decade and a half at an alarming rate. 181 have closed, at least 181 since 2005. That includes hospitals that have scaled back services as well as completely closed altogether, and I'll break those down a little bit more specifically. You can see the geographic distribution of the hospitals that have closed, overrepresentation in the American Southeast. Texas, my home state of Tennessee, have experienced a very high number of rural hospital closures. If you look at the bottom here, you see year-over-year closures, and the trend, at least up to 2020, was a slow and steady increase year-over-year. 2021 was a strange year because there was a lot of federal funding that flowed into the system to buoy hospitals in the COVID-19 pandemic, and so only 2 rural hospitals closed in 2021. So the concern is going forward, once the state of emergency ends, what will happen? If we break it down pre and post ACA, pre-ACA, the blue dots represent hospitals scaling back services or closing, and the yellow dots are since the passage of the Affordable Care Act. So it challenges the thesis that the Affordable Care Act has prevented rural hospital closures, or that the funding that the ACA provides has been a staunch or stop to some of these trends. We've actually seen them continue and accelerate. Another way to look at these, 155, this was as of 2019 from Statista, and you can see the trends. Again, they're pretty unmistakable. Hospitals that close cause all sorts of downstream consequences that I'll talk about in a moment as well. Here's a little bit of a breakdown of some of the data that I looked at, and a lot of this is from UNC Sheps Center, so if you're interested in this topic, they have really good data on very kind of specific granular characteristics of the hospitals that have closed. 97 have completely shuttered since 2005. 83 have substantially scaled back services. As I mentioned, 2020 had 19 rural hospitals that closed. Probably the most dramatic statistic that I came across was that at the end of 2019, so that's pre-COVID-19, as many as 40% of rural hospitals were operating at a negative margin, meaning they were spending more money to treat patients than they were getting reimbursed. And that is not a healthy trend, of course. COVID has exacerbated these trends, continuing with the theme that we've talked about over the last 24 hours, by both cutting patient census, so people not going to the hospital as much because of a fear of contraction of COVID, and then those that do go to the hospital are more complicated, complex cases that take more interventions, which can be more expensive for the hospitals. Putting in the context of Appalachia, we see rural hospital closures throughout the spine of the Appalachian Mountains. Counties represented here by dark green are counties that have experienced a rural hospital closure. 20% of hospitals that have closed since 2010 have been in an Appalachian county, including, as I mentioned, my home state of Tennessee, and even my home community of outside of Knoxville, and stretching all the way down to North Georgia and into Alabama as well. So what does this do when hospitals close? What does it mean for the people who live in the communities? Again, this is not news for anybody in the room. Studies have shown that when hospitals close, mortality rates in communities rise. There is a correlation between a hospital closing and an increased death rate in the community itself. It impacts elderly and low-income patients the most. Again, that's not surprising. And it's had particular impacts on specialty care, emergency care, mental health and substance use, as well as obstetric care, which was mentioned yesterday. More than half of rural counties in the United States now lack hospital-based obstetric services, and that, of course, causes all sorts of downstream consequences, one of which is increasing pressure on ambulances. So ambulances have become more and more the frontline mobile emergency room that treats people in lieu of a community hospital. There have been a lot of anecdotal stories that I've read over the last couple of months of people requesting an ambulance and then requesting not to be taken to the hospital due to concerns over having to travel back home once they get discharged from the hospital, and trying to basically put pressure on EMTs to treat them at their homes, which makes sense for people who might face challenges in transport, of course. We know that rural hospital closures reduce access to emergency care. We know an emergency room is the most expensive thing that a hospital can run, and oftentimes emergency rooms are the first to go when we're talking about the rural services that are scaled back. We also see access to obstetric services in rural counties declining. This is 04 to 14. A study in Health Affairs found that obstetric services had already started their decline pre-Affordable Care Act. That has continued. And there's all sorts of interesting data in the study, including this map, which shows counties across the country. The kind of middle blue color is counties that have no obstetric services. Navy color represents counties that have had full closures of obstetric services, and the aqua color is counties that still have obstetric services. And again, this is as of 2014, so map has worsened since 8 years ago as well. So what about persistent financial precarity? Well, we can split up hospitals into urban and rural hospitals, and we see that rural hospitals are overrepresented in the amount of hospitals that have low margins. Many of these margins, like I mentioned before, are negative, meaning that the hospital spends more in treating people than it takes in reimbursement. We can talk about why that is. You can look at where rural hospitals are located. This is from the Center for American Progress, and then this is just based on percentages of rural hospitals that are low margin in different states. You see the Great Plains and Texas being represented here, and of course the other states that we've talked about in the past in the American Southeast and the Intermountain West. In terms of comparing hospitals, rural to urban, and which ones particularly struggle, we see that those hospitals that have smaller amounts of bed sizes and those that have obviously low occupancy rates struggle the most. It is not necessarily the case that the trend holds for urban hospitals, but when we're looking at rural hospitals, the smaller the hospital and the lower the occupancy rate, you can easily identify the hospitals that are going to be struggling. Pretty straightforward conclusion, right? In terms of what happens when a rural hospital closes, how close then are you to the next rural hospital if you need emergency care? If you're in an urban area, you see that for 52% of urban closed hospitals, there's another hospital within 5 miles of that urban hospital that closed. In rural areas, particularly low margin rural areas, only 5% of hospitals that have closed have another hospital within 5 miles. And in fact, the majority, or the plurality, 45%, are 20 to 35 miles. So when we lose a rural hospital, we're not just losing a competitor in a market, we're actually losing the only option in the market. Right? 35 miles away is the plurality that individuals have to travel. Here's North Carolina. Again, this is from the UNC Shep Center. Pink dots represent the financially threatened hospitals, and blue are hospitals that have closed. Again, you see it's not easy to pinpoint geographically where this is happening. It's throughout the entire state, including the western mountainous part and all the way to the east. So what else happens when a hospital closes in a community? Supporting industries suffer. Industries that support the hospital, like providing food or doing laundry services or construction, also dry up. Physicians leave the area. Other healthcare providers leave because obviously they've lost their jobs. Recruitment then becomes difficult in the future the likelihood of recruiting a physician to an area that has recently seen a hospital closure, some studies have suggested is very difficult. And those that do go then are asked to do more and provide more services. So services that they may not have specialized training for, including palliative care, mental health, obstetric care, all the types of specialty care that we're talking about are lost when a hospital closes. There's also this sense of malaise that descends in the community, and a sense of loss. Number of stories that I've read of people, news articles that I would peruse of people losing a sense of pride or a sense of the public square or their community when a hospital left. And that's not accounted for in any of this data, but it's important to recognize as well. So what are the federal and state, and we're talking about Medicaid expansion, solutions to this problem? The thesis here is the interventions are a good attempt, but they're not holistic, and they're not likely to work quickly. And I think that's something that is important to observe. So first, we'll talk about Medicaid expansion, then we'll talk about what's known as CHART and the Pennsylvania Rural Health Model, and then new Medicare category for certain hospitals known as REHs. So the role of Medicaid expansion can't be denied in rural hospital closures. This is the map that those of us that teach health law are constantly looking at and updating, I guess, over the last couple of years, right? And then there were 12, that's what this map is. We've recently had Missouri and Oklahoma. I know Professor Farringer is going to go into more detail about those processes, those states that have expanded their Medicaid programs over the last couple of years. But we still have a persistent 12 that have not expanded. South Dakota is going to look at a voter initiative, or is going to engage in a voter initiative this summer, so we'll see if that passes. So there's a chance South Dakota could be the 39th state that expands Medicaid. Just to bring us up to speed on this, right? Under the Affordable Care Act, the Medicaid expansion is mandatory, at least as the statute was passed in 2010. The Supreme Court decision in NFIB versus Sebelius makes the mandatory nature of Medicaid expansion voluntary due to excessive use of coercion, basically, according to Chief Justice Roberts. So states have had the choice whether or not they expand, and that's where we are now in 2022, 12 years after the Affordable Care Act. I do tell my students, though, that Medicaid took time. Arizona was the last state to accept Medicaid as a program, and that was 17 years after Medicaid came online in 1965. So maybe it's par for the course that it takes time for states to accept the program. The data is overwhelming. Hospitals in states that have not expanded Medicaid have seen more financial precarity than states that have been than hospitals that are in states that have accepted Medicaid expansion. If you're just thinking about dollars flowing into the hospital, the percentage of patients that hospitals treat that don't have insurance is really important to the bottom line of that hospital. The hospital has to treat everybody who comes in who's suffering from an emergency medical condition under a statute known as EMTALA, and the hospital then has to seek reimbursement to pay for that care. If you're a private paying patient, if you have private insurance, your insurance will pay that hospital at a higher rate than if you're on Medicare. So if you're 65 or older, usually, there are exceptions. If you're on Medicare, generally, that pays a higher reimbursement rate than Medicaid in most states. And of course, if you're on Medicaid, that's better for the hospital financially than if you're completely uninsured altogether. So we see differences in expansion states from non-expansion states when we're looking at uncompensated care in states. This is a little bit hard to see, but the bluish line that's near the bottom is expansion states, and you see over years the percentage of uncompensated care that basically has dropped versus non-expansion states, which is represented by the red line. And you see the uncompensated care rate has changed a little bit in the positive direction, but that's because of the other gains, I think, made by the Affordable Care Act. Kaiser has done a meta study and put all this together and said pretty definitively that additional studies demonstrate that Medicaid expansion has significantly improved operating margins and financial performances for hospitals, other providers, and managed care organizations. So it's pretty well held. We also see that when states expanded Medicaid, the share of uncompensated care that the hospital provides drops as well. Another study that shows the same thing, right? Percentage of uncompensated care by Medicaid expansion status. You see the lines diverge between the hospitals that have expanded and states that have expanded and those that have not. In Tennessee, how many people county-wide would a Medicaid expansion cover? That is up to 138% of federal poverty. It's really throughout the state. So the rural south central part of the state as well as the mountainous eastern part of the state have high percentages of people who would fall into what's known now as the Medicaid coverage gap. So states that have not expanded, but who would actually be covered through Medicaid expansion. Another way of expressing this, we see expansion states, hospital closure rates, the numbers drop post-ACA. Non-expansion states, the numbers continue to increase. I know that Professor Farringer is going to talk more about the American Rescue Plan of 2021, as well as the Build Back Better Act and what it does to change funding streams for states or try to entice states to expand their programs. So I'm not going to go into depth here, but just know that the federal government has continued to try to sweeten the deal to try to get states to expand Medicaid by increasing the amount of funding that the federal government provides states to cover the expansion population. So in the American Rescue Plan Act, which was passed last spring, the federal government put a 5% bump on the table for states who would expand Medicaid. That actually applied to their traditional Medicaid population. So the Fed said, if you expand Medicaid now, we'll bump your funding for all the other Medicaid recipients that you're already paying for, we'll bump our contribution by 5%. Most states get, or all states get, between about 50 and 75% from the federal government to fund their Medicaid program. So we're talking about a 5% bump is not insubstantial. We also currently, because of the COVID emergency, have a 6.2% bump. So states are actually getting a lot of help through the Medicaid funding mechanism right now, at least, and that's why you see hospitals in 2021 that didn't close it as frequently. We also see that if states take this additional deal, it's very fiscally beneficial. The cost that it would take to provide health insurance through Medicaid for an additional expansion population is lower than the amount of increased reimbursement that states would get, as well as other benefits too, tax benefits, et cetera. Okay, so let's talk a little bit about CHART and the Pennsylvania Rural Health Model. So what are these? So CHART is the Community Health Access and Rural Transformation Program, and it's very similar to the Pennsylvania Rural Health Model as well. So what are these? These are pilot programs that the Centers for Medicare and Medicaid Services have undertaken. CHART started under the Trump administration and is basically still kind of in the implementation phase. The Pennsylvania model is a little bit farther ahead. And basically what the federal government has done has said, we're going to waive certain regulatory requirements for certain rural hospitals, and we're going to move your reimbursement to what's known as full predicted capitation. That means instead of fee-for-service, which is highly dependent on the number of patients you see as a rural hospital, that's the traditional way Medicare would pay, that's per Band-Aid, that's per patient, that's per service. It's wildly inflationary and it ebbs and flows, right, based on the percentage of people who come. Instead of that model, we're going to replace it with predictable capitated, which is basically like the beginning of the year. This is a total simplification of it. Here's a bucket of money, do with it what you wish, right? And use this bucket of money the most efficient way possible and try to save the system money. That's the short, description of Medicare Shared Savings Program. So what they're trying to do is get hospitals to be more conscious of the costs that they incur by treating people and give predictability so that just like personal finances, when you have predictability in your budget, you're able to plan for how you spend your resources. This includes cost sharing for Part B, so patients who come don't have to pay co-pays, transportation support, expanding telehealth, which we've talked about, reclassification. You can become a different type of hospital, which gets more reimbursement based on the facility. So all these kind of new ideas in the health policy wonk world that suggest that this would make it better for rural hospitals. We have these programs already on the books through accountable care organizations, but rural hospitals have had a really hard time creating accountable care organizations because they don't have the resources. If you think about the health system that has to comply with all the data requirements and implement the individual professionals to comply with all the data requirements under an ACO model, to get money, to save money. Rural hospitals don't have those resources. They often don't have somebody who is a data analyst who can comply with all these difficult requirements. So this kind of pauses the world for a moment for these 4 lead organizations in 4 states and allows the hospitals to be creative about how they come up with their reimbursement strategies. So what's the Pennsylvania rural health model? Very similar, but it's a little bit ahead. So it's the 3rd state-specific model that CMS has approved. For those of us that teach health law, we know about Maryland's all-payer rate for hospitals. So Maryland is a strange in a good way, state in terms of paying hospitals. Vermont has a similar model that CMS has approved. Pennsylvania is now the 3rd state with a state-specific model, but it's focused on rural health. It's the same thing. Capitated global amounts for hospitals so that they know kind of what their bottom lines should be, and it's enticing. So hospitals get higher reimbursement rates. If you're a critical access hospital, CAH, or an acute care hospital, you can be a part of this program. It requires financial targets as well as quality targets, and they just issued the 2nd report, CMS did last year. There have been some problems. Hospitals struggle to meet quality metrics. So there are 3 main areas where CMS is interested. Did you increase access to primary and specialty care? Did you reduce rural health disparities through improved chronic disease management? And did you decrease deaths from substance use disorder and increase access to opioid treatment for opioid abuse? There's long-term challenges. Hospitals say a lot of the resources that we need right now, a lot of the investments that we need to make are still difficult because we don't necessarily know what's going to follow this model. And so us undertaking some major resource-intensive shift still is difficult. And if they're unaffiliated hospitals, which many rural hospitals are, so they're not affiliated with an academic medical center or a university or a health system, that's a lot of financial risk to put on the table. REHs, this is the last category, and then we can move past all the regs and talk about the fun stuff, right? Which is, so what are REHs? Rural Emergency Hospital Services. Medicare, as of 2023, we're still in the rulemaking process, but January 1st, 2023, Medicare is going to create a new category. So you have critical access hospitals, you have academic medical centers, you have all these types of hospitals that Medicare pays different rates to based on what you do in the community. REHs are a new category. These will be hospitals that do not provide inpatient services, but provide emergency and outpatient hospital services. So Medicare has said, for some rural communities, if inpatient hospital services are not financially feasible, we want to try to incentivize you to not close your emergency room. That's basically what this is. Please keep your emergency room open. If you have less than 50 beds, you're a critical access hospital, you're already a rural prospective payment system hospital, you are eligible to qualify as an REH. You must, however, staff your emergency room 24 hours a day, 7 days a week. And if you do this and qualify, we will bump your allocation of reimbursement by 5%. So you get a 5% bump through the Medicare program. We don't necessarily know the contours of this yet, but this is the sketch that we've seen CMS tell us. Again, what is the federal government doing? Sweetening the deal, trying to get hospitals to make a financial decision that would benefit the community. So what are the takeaways here? And then I'll wrap up. What do we think about some of these interventions? Well, in some ways, they're innovative. You know, they're technocratic to the extent we like that, like turning dials. But they're weak, right? They're demand-side subsidies. And we've seen health policy go this route a lot, right? Which is, we don't have really efforts or trends to control the ex-ante cost of healthcare, right? We don't regulate the cost of prescription drugs. We don't tell hospitals what they can charge. The policy interventions so often give assistance to patients to pay those high costs. That's been the regulatory intervention of choice. That's exactly what these are. The problem, of course, is if you don't deal with the ex-ante inputs, then you're constantly behind the 8 ball, right? You're constantly subsidizing more and more to help patients access care, to keep hospitals open, instead of sitting down on the front end and saying, what exactly are the supply side interventions we can make? What are the seller side interventions that would be successful? And we've seen that, right? This reliance on public, payer side, and voluntary programs for solutions. So CMS has control over Medicare, so they can turn the dial on Medicare. But what about the people that have private paying insurance? What about the people that are uninsured, right? So Medicare is, in some ways, a partial solution to the problem. It's limited federal power. It's relying on the power of Medicare's conditions of participation and conditions of payment, right? This idea that hospitals will have to care about this because they have to accept Medicare. They don't have to, though, right? But it's basically layering more regulation on the back of Medicare to get into the hospital in the first place. What about Medicaid expansion? Well, we've seen this kind of popular disjunct between state legislatures where Medicaid expansion in the holdout states have not been successful, but when we go to the voters, it has been successful. So we have this popular disjunct between state legislatures and the actual direct voter. And we see states that you wouldn't think of as expanding their Medicaid populations programs as being successful when we have voter drives. South Dakota, I mentioned, is this year. But what are the challenges with this type of intervention? Well, the states have a lot of leverage here, right? A state like Tennessee could go to the federal government and say, we'll expand Medicaid under these conditions. And in some regards, people argue that, is that appropriate? Like, should the federal government be willing to negotiate on some of the contours of Medicaid to try to entice a state to expand? There's a lot of tension there. And you talk about work requirements and the like, if you talk about those in health law. They're limited in scope, so they're fractured, right? The population, we're talking about a small population of overall patients. Huge impact in rural communities, but not a holistic solution to the problem. The bonuses that have been offered are time limited, right? They go away after 2 years under the American Rescue Plan. And this perception that the federal government is unable to solve the challenge, right? This idea that if the federal government is begging states to accept Medicaid, there's something fundamentally weak about the federal government in that context. What about Medicare reimbursement? Well, we're using the streams that already exist to try to sweeten the deal, to try to make it so that hospitals can be buoyed by these financial increases. Again, it's helpful, but not immediate, right? The pilot programs, the CHART program is not anticipated to end until 2028, and then we'll have data to see how the hospitals did. It's limited in scope, like Medicaid expansion. Will it work? We don't even know. And then what I think is probably the most threatening piece of this is this idea, at least that we see from the current makeup of the Supreme Court, that there is an increased hostility to the administrative state, that there seems to be a movement, if you follow some of the cases, the vaccination mandate cases, in the current Supreme Court to be quite hostile to the use of federal agencies to make law, and a question as to whether or not they have the authority to do certain things. And there could be an argument in some of these cases that Medicare is overstepping its mission, right? By trying to tinker with, trying to prevent rural hospitals from closing. That's not necessarily why Medicare was created, right? And so I think there's an argument that has continued to kind of fester that may come back again under this current Supreme Court. So other observations, then I'll wrap up. Basically, what I think of is what's missing from the intervention. Some kind of paradigm shift, right? Some supply side hard regulation about what it is we need, what it is rural hospitals need to stay open, right? Instead of turning the dial and increasing the reimbursement, what is it that is so financially difficult for hospitals? Is it the patient-payer mix? We think we know that. So let's alleviate that burden by funding rural hospitals on the front end. Oh, sorry. Geez, sorry. On the front end, right? Of trying to prevent those types of things from even occurring in the first place. In previous work, I've looked at what states do in different areas of healthcare policy. States act in so many different ways in health policy. States can exert a lot of hard power in the legal realm, can be regulators, can be prosecutors, can be payers, like through Medicare and Medicaid. The state often in these contexts acts as payer. It has adopted the consumer paradigm. It's just another payer. Right? We're going to use our funding mechanism to try to incentivize or change behavior instead of relying on harder regulatory power. To say we're going to create, through public regulation or public utility regulation, a new vein of regulation to try to incentivize and preempt any problems for rural hospitals. Instead, they use the kind of context and paradigm that exists. We don't see legislative solutions from Congress. And so there's a lot of pressure on the agency to get more creative, right, to try to solve these problems. So that's, again, raises the pressure on Medicare and Medicaid to try to solve these. So what's the takeaway? Well, maybe Professor Farringer can give us a little bit of hope in a few minutes. But I think the takeaway is that we kind of need a radical redesign. And the time is now. Time is of the essence in these hospitals. We see that through the COVID-19 pandemic. Hospitals are even more financially precarious than they were before. Not only does it lead to all the problems that I talked about, but it also leads to a saturation of the marketplace when we've got mergers and acquisitions, hospitals being precarious and then joining a hospital system. And we see what happens after that happens, prices rise. So there's real problems here for the consumer-based paradigm to try to use them to try to solve this problem. So I'll leave it at that. Thank you for your attention. I look forward to the questions. Thanks for having me.
All right, does anyone have any questions? Oh, Professor Blake.
Uh-oh.
Okay, it's working, great.
So you're speaking my health law nerd language now, and I'm like so excited that you could come and present on this. I have two questions, and they're completely unrelated, but I couldn't control myself, so I'm going to ask you both. Okay, so one, that the chart program to me feels a little weak sauce, right?
Weak sauce.
And I guess what it reminds me of is the debate that we had a few years back about Medicaid block grants, right? And the idea of, you know, let's just give the states a bucket of money, and when they run out of the money, well, no one wanted to talk about when they ran out of the money, right? The idea was basically, here's a block grant, it's better for you, when really it was actually better for the federal government.
Yes.
Not better for the states. And in some ways, this ACO model and this chart model feels a little bit like that. Like,
Yeah.
I'm not convinced it's going to be a win for rural hospitals unless, you know, it's enough money in the bucket. And I guess the other piece of it is, does it expose rural hospitals to some, anytime you sort of put the money into one bucket, it's easier to take that bucket away, right? Rather than, you know, when you say fee for service, you know, we pay you for what you do, that's harder to kind of, if you're, say, you know, an administration who comes in and wants to deregulate and wants to clamp down government spending, it seems a lot easier to do that when the model is, here's a bucket.
Absolutely.
And so I would be curious what your thoughts are on that. And then I have another question, I'm sorry.
Okay.
Which is, I would just be curious if you have comments about the trend of hospital consolidation and how this plays into that. You know, I know many of you are aware of, in Western PA, we had a pretty aggressive nonprofit hospital system that was buying up a lot of rural hospitals and a lot of urban hospitals, and sort of waiting to see how they do, and if they perform badly, just closing them.
Yeah.
So, you know, I would be curious how you think kind of, you know, bigger nonprofit hospitals purchasing some of these smaller hospitals, how that plays into all of these trends.
Yeah, that's great. So on the first question, I think the more that I looked at this, I kind of thought we need a shift in kind, not just degree, to these problems. Like, we can't treat the rural health crisis as we treat other crises. We can't just turn the dial on Medicare and be like, that'll solve it. Let's just create a new category, even though I just spent like all this time telling you about these categories, right? Yeah, thank you, yeah. It just, you know, it's like when when all you have is a hammer, everything's a nail, right? Like just, oh, hospitals are closing, well, let's turn this dial. You know, to me, it's like, that's not going to get us anywhere. And I think you're right, it is weak sauce. I think it's potentially threatening for future budgets. I think that's troubling. And I think that there is a real concern that these just are not going to work. And this tension that I find interesting, at least when I teach these issues, about like when you bring up block grants, is Medicaid negotiable, right? Like, is the statute of Medicaid, is the heart of Medicaid, like the core of what it does, can the federal government negotiate it away to try to get states to sign on? And at what point does that exercise become immoral, right? Or beyond the scope of what the federal government should be doing? You had the arguments in Virginia about work requirements, Tennessee block grant, which is actually kind of on ice but still alive. So yeah, that's a real problem. And then it's, you know, federal regulators who are making the choice, like, we'd rather have you as part of this watered down Medicaid program so we can cover you. But, you know, a lot of Medicaid scholars, which I love, frame it as like this is a battle over the soul of Medicaid, right? Which is like, what is Medicaid for? So I totally agree with all your points in your first question. The other question on consolidation, that's, you know, how dark do we want to get? Because that's darker too, right? I know it's early. And it's rainy and cold, but sorry. But, right, that doesn't solve, and people are like, oh, just try to, you know, that's why M&A was gangbusters over the last decade. We're seeing kind of a plateau or a downturn in terms of horizontal integration, so we're seeing less hospitals merge, except for maybe in Western PA. But we're seeing vertical consolidation at an alarming rate, right? So hospitals that are buying physician groups, we're seeing those trends continue upward. And then you've got physician groups who are covered by the corporate umbrella who have the ability to raise prices with impunity. We see that. Like, there's correlation between saturation in the market and the prices that follow. So that's a problem too. Now for the rural hospital, again, it's a trade-off. It's like this, that I often tell my health law students about. Like, would you rather have a bad hospital or no hospital, right? Would you rather regulate this hospital to death when it makes all these medical errors? Or is it better to have a hospital that does have quality failures? Like, what's the balance here? And I think that's the same question here, right? Rural hospital might be excited to be acquired, but then the reality is, if you've got, you know, corporate profits that are extracted from that community, you know, what are you doing to access in the end? Again, I think most of us would say we'd rather have the hospital for the ER. I think that's right, for the obstetric service. But I think it's a hard trade-off, and it's not a solution. So this is where I just ramble, and then I need my microphone to slowly volume to go down, right? Because there really isn't, but thank you for the questions.
No, that was great. No.
Thanks.
Thank you again for speaking. So I wanted to know if there's a difference in disparity among closures and partial closures, and even difference in incentives for nonprofit tax-exempt hospitals versus for-profit hospitals.
Oh, great question. I didn't look specifically at that. I really, oh, God. I'm trying to decide how I want to. The recent piece that I mentioned off the top about hospital lawsuits of patients, we see there was a study in Virginia done. This is a little off topic, but it makes a broader point that I think is responsive. They found that 71% of the hospitals that were suing their patients for unpaid medical bills, like, you know, wage garnishment, et cetera, were nonprofit hospitals, 71%. So we think of nonprofit hospitals in a certain way, but when you drill into it, you kind of see that sometimes it's not necessarily what we think of it as a charitable institution. So I don't know. I don't know about the closure nonprofit versus for-profit. We do know that for-profit hospitals typically have lower quality metrics than nonprofit hospitals for obvious reasons. There's an incentive to skimp on care in for-profit hospitals. But I don't have data on the closure. That's a really good question. Thank you. I don't know. I just attack nonprofit hospitals now. It's like, who else wants to be attacked? Besides Medicare, right? Yeah.
Here and then you. Oh, okay. He is past the mic.
So I do know a few statistics actually
good, yeah.
about for-profits. And so disproportionately what kind of is happening is these are largely community, sort of municipality, county, city-owned hospitals that have like been struggling, and the response from the city council, county council, whatever, has been to sell it or lease it to a for-profit. So a lot of what is happening in these rural hospital closures is a for-profit company who has come in thinking they can turn it around, and then they come in, and when the numbers don't work, they're like, well, we can't make it work. Like, we're just going to shut it down. And so I was going to ask that same question, sort of on a related note. How does that, knowing that information, how does that impact, like, giving them a bucket of money and some of these programs that seem like, if I'm giving it to a for-profit company whose goal is to give shareholders money and bottom line at the end of the day, how does that impact maybe the efficiency or efficacy of these programs, do you think?
Great question. And I appreciate that we've fronted that. That's a major issue in healthcare that we're seeing now is investor dollars flowing out of for-profit entities, which I think is at a quite alarming rate. And you see that with ambulance companies, you see that with hospitals. So I think that's a problem. You know, I don't know. Again, I think it seems to me like a values question, which I think are the most interesting, but they're kind of unanswerable, or they're answerable by all of us, which is, you know, what is it that defines the hospital itself? Is it the professionals? Is it the building? Is it the public mission of the place? Are we losing something when we convert it to a for-profit entity? I think we would all agree that we are losing something in its DNA, but we might make that trade-off because the alternative is worse, right? I think that's unfortunately a lot of what the world in which we inhabit in health law sometimes is, right? You're not making these decisions in a vacuum, and you're advocating for things that may not be optimal solutions, but they're better given the alternative. And so I think that a solution like CHART, I mean, it's geared toward a nonprofit, critical access, small hospital. Like, you can imagine that hospital that's perfect for something like CHART or for the REH classification. But for a investor-owned, roving corporate parent that is seeking to extract, the model doesn't really work very well, right? And again, I think that goes back to what I was looking at, which is, are we solving holistically the problems in healthcare? I don't think we are through these solutions. Now, they're not bad, and the people that design them are not bad people. Like, they're trying to make lives better. But I think that it shows kind of how we've gotten, at least in health policy, stuck on this idea that we just need to intervene on the demand side. We just need to help people more. We need to give them more subsidies. We need to cover them more through insurance, instead of thinking, like, how actually could we tackle the problem holistically on the front end? So it's easy for me to stand up here and just make that critique. It's harder to come up with a solution, but great question.
So I'll go ahead and do the next one here.
Yeah.
First of all, thank you again for coming to speak with us. My question is about the effect of open hospital prices and that effect on the payer system that we have now. Has there been any data from states that have implemented, like, open cost structure laws, and whether that has actually been effective?
Yeah, it's another great question. We have price transparency laws. That's kind of been a rage across the states. Again, I would, caution us to ask whether the paradigm works, which is healthcare a consumer good, right? Do you study prices before you go? Well, first of all, you don't know what the prices are, right? Do you quality compare before you go choose a doctor? Are you able to go to Kelly Blue Book and price out how much an open heart surgery should be? Are you able to dig into the history of your doctor and find out what kind of errors they've made over their career? I think the answers are no, right? You're being wheeled into the emergency room in pain, bleeding, right? You're not choosing anything. So I think that state interventions that treat patients as consumers are doomed to fail. And I don't think, and I know that's strong, and maybe there are some cases where they work. Many price transparency laws actually that I think have been most effective. Louisiana has a model where they, at least in the drug pricing context, I'm most aware of those types of laws, where they report average list prices to the Attorney General, and then the state apparatus then uses that data to decide what types of drugs would be covered by Medicaid. Those I think are better, because the state is then can kind of act like a consumer on behalf of the patient population. But releasing it to individuals to make decisions, I think leaves people adrift. And I think that again, is this kind of paradigm that we're in, right? Which is like tinkering with the reimbursement, giving more information to patients to make better decisions will make it better. And it just doesn't seem to work. Like, think about it, right? You go into the hospital, let's say you have all this data. It's like 3.8 stars out of 5, right? You feel pretty good, right? And you go in, and then they're like, okay, this is gonna be $1,700. And you're like, is that gonna improve my life? Of course it will. Is it worth it? I don't know, right? Versus like, this loaf of bread is $12 and this one is $1, right? Well, how much do you value your bread, you know? Healthcare just is not, it doesn't lend itself well to that kind of thing. And then on top of all the other power disparities that exist, right? The patients that come in that are not going back to health literacy, unable to understand some of the risks that the doctor talks to them about, language barriers, cultural barriers, racial disparities, I mean, all sorts of things intervene as well. So it's just really hard to think that solutions like that are good. They give state politicians and policymakers something to trumpet, like we're doing something, right? But it's like, you can tell me that an EpiPen is, you know, $100,000 all day long, and it doesn't change the price of the EpiPen, right? So to me, it, you know, sorry. Again, I just fade out.
No, we appreciate it. Does anyone have last questions, Kate?
I'm so sorry. Like, this is the last time we invite this guy back to this place.
No, thank you so much for coming. And I have a question that's pretty related to what Professor Blake initially asked, in that, and I suppose it's a little blasphemous to talk about WVU purchasing some hospitals. But you know,
recorded? Yeah.
we have some, you know, like in Summersville, there was a hospital that was recently, you know, going to close, and WVU purchased it. And like you mentioned, I think for most of those communities, when it comes to, you know, having no hospital or WVU buying it, the option obviously is WVU buying it.
Right.
But you know, when it came to COVID and sort of like distribution of some resources, like the mononuclear antibodies, that treatment that they had originally, some really small hospitals in West Virginia were getting shipments of those in regularly. And I'm from a very small town that has a very tiny hospital, and we had a little clinic. And then at some point, you know, the federal government kind of just only wanted to give them to WVU and have WVU sort of distribute the resources as they saw fit. And so how has that, or even if you know, kind of impacted how, you know, resources like that are going to get distributed to hospitals when, you know, kind of the federal government kind of looks to, okay, well, yes, there's 20 hospitals in the state, but you own, you know, 12 of them, so we'll just give it to you and you distribute it. And then those 8 hospitals are just out of luck.
Yeah, it's a great question. So yeah, there are 100 different depressing things I could tell you. One is, you know, like I think about the adage that I think I don't know if I don't want to speak for all of us that teach in the area, come back to that the healthcare system in the United States is not a system. It's a non-system, right? It's a collection of different types of systems that kind of interact. And so I think people would respond to that by saying, like, that should be a policy decision. That should be a public decision. People should be making decisions based on access and not just entrusting a, university academically affiliated medical center to make decisions to distribute important treatments. But we see that, right? We see that through the vaccination rollout. We see that through, getting masks in the mail. It's clunky, right? There's no easy way to do it. I will say, maybe this is a little hopeful. The thing I was thinking was, there are benefits, there are some benefits to consolidation, right? And one of the benefits of consolidation is standardization, right? And training and sharing expertise. So in Upper East Tennessee, we had a merger, Mountain States and Wellmont, if anyone's from Southwest Virginia or Northeast Tennessee or has been there, and they formed Ballot Health, which has had all sorts of publicly reported problems in the last year after the merger, access-related issues, closing hospitals in Southwest Virginia, et cetera. But the good thing is that Ballot doctors can go to different places, right? So, and the systems are the same. So there are some benefits, right? That if you can standardize efficiencies across a big system like that, that's getting somewhere than the fragmented world in which we live. So I don't want to, say that everything is bad. So maybe, if WVU had connections to all, 55 counties, that would be a good thing, right? It's not just because it's a, major, not corporate, but right, university-affiliated parent doesn't make it a bad solution. The issue is, do we have some consolidated entity that can make decisions on a systemic level? So I don't want to leave us all completely down. I think that there are some efficiencies that you can get in that way, and maybe consolidation in some ways is a good thing on some level like that. But to me, it still comes back to the ultimate point, which is, why aren't we doing, why isn't the state doing that, right? Or why isn't the federal government doing that based on population, bang for your buck kind of thing, right? And then also supporting partners on the ground to get it to people who need it in areas that are hard to reach, instead of entrusting it to Walgreens, right? Go to Walgreens and get your whatever, or WVU Hospital, or whoever it is. It's because we don't have a separate mechanism, like a lot of other countries do. So anyway, as you get into these things, you start wanting to redesign all sorts of different aspects, right? But I appreciate your question. Thank you.
I believe we are out of time, so a round of applause for Professor Buck. And I believe this is the one time that Jalen did not schedule a break. So
Oh, sorry.
So out of character.
I know.
And for the long-winded guy, too. Jeez.
No, you were lovely. Thank you.
Thank you again, Professor Buck. Next, we're going to be introducing Dean Deborah Farringer. Dean Farringer is the Associate Dean for Academic Affairs, an Associate Professor of Law, and the Director of Health Law Studies at Belmont University College of Law. Her scholarship focuses on health law and policy, primarily related to healthcare compliance, including health data technology, fraud, abuse, and privacy issues. Today, she's going to be presenting her paper entitled Medicare Expansion Expectations.
All right, I would love to say that I'm going to be super hopeful, and this is going to be really like taking us in a better direction than Professor Buck, but I'm not sure I have that much to say that's necessarily all that much more hopeful, but thank you so much to Jared and Jalen and all the West Virginia Law Review folks. Thank you to Adam for driving me yesterday for an hour and a half. I'm sure that's not fun. And this has been great. It's so great to be able to travel back and be introduced to everyone. This is my first time to Morgantown and my first time doing anything other than just driving through the state, so it's been great to see everything. I am going to talk today luckily, Professor Buck has led the way for, you have already been sold on the fact that we know that Medicaid expansion is something that has been very, very beneficial for rural hospitals and rural hospital closures and trying to stem rural hospital closures. So a lot of the sort of data that I'm going to talk about is something that I think has already been presented and is well documented in lots and lots of studies. So I'll kind of rehash that a little bit and then talk a little bit more specifically about whether or not our 12 remaining states, and I kind of put Wisconsin in its own bucket because Wisconsin's sort of doing their own thing that really is sort of quasi-Medicaid expansion already. So I'm going to sort of put that aside and think really about the 11 kind of Midwest, Southeastern states that are left and talk about the current plans that are out there to try and get them to expand and give you an idea about whether I think that any of those things will happen and the increasingly narrow window for that to occur. So I'll just get started. I have sort of here's my kind of roadmap for where we're going here. I'm going to talk a little bit about the rural hospital closure crisis and how we got here with some sort of personal stories from Tennessee and a little bit about the statistics of where places are closing. And a lot of it we've heard just in terms of some of the big statistics as to the picture, so that's great. And then I'll talk specifically about Medicaid expansion and hospital financial stability, comparing our non-expansion and expansion states, and then focus really on our currently available proposed solutions. So one that's already in place, the American Rescue Plan Act of 2021, which is that 5% booster that Professor Buck talked about that really actually already started. So our 2-year window is well on its way. And then also the Build Back Better Act. And there's been some other proposals, but I'm going to focus primarily on the Build Back Better Act, which should be near and dear to West Virginians' hearts since it's your senator that seems to be telling everyone that we will not enact it. But I will say, I think I'll be critical a little bit of what's in there as to the I'm going to talk only about the provision that affects Medicaid expansion and what they're trying to focus on for Medicaid expansion. And then I'm going to talk about the likelihood of success of those plans, what I think will happen with those plans, whether I think that the American Rescue Plan, Build Back Better Act, or just existing sort of statistics regarding the benefits of Medicaid expansion will actually inspire any states to do anything and what our next steps should be. So this is a picture of Jellicoe Community Hospital, which is about 60 miles northeast of Knoxville, Tennessee. It closed for the first time. It says on their emergency room temporarily closed. It closed to stop seeing any inpatients at all in November of 2020. So technically it's in a 2020 hospital closure category. They did keep their emergency room open through March of 2021. It was owned and operated by a sort of small for-profit for a very short period of time after the city council had sort of given up and leased it to this for-profit hospital company. There is supposedly a company out of Indiana who has purchased the hospital but has yet to be reopened. And it's just an example of what many stories that are happening in the state of Tennessee. And some of this actually came to my attention. I have just rolled off as the chair of the board of directors for a nonprofit law firm called the Tennessee Justice Center that is based in Nashville but focuses on health access issues for all of Tennessee. The founders of the organization were legal aid, just out of law school, fresh out of law school, worked at a legal aid clinic in Nashville. And they had a class action lawsuit that they were filing against TennCare, Tennessee's Medicaid program. And right around that time, Congress passed a law making it forbidden that legal aid programs could file class action lawsuits. And they said that if you file class action lawsuits, you will not receive any federal funding for your legal aid services. So the two attorneys, like one just fresh out of law school, decided to go ahead and start their own nonprofit law firm, which was Tennessee Justice Center about 25 years ago. And then they filed their class action lawsuit against the state of Tennessee for its TennCare program. They won. They have been filing lots of lawsuits against TennCare since, and primarily their focus is health access mostly focused against sort of Medicaid and Medicaid disenrollment issues. We've had a lot of issues over the years regarding like readmission applications and re-enrollment where they send it to the wrong address and then you just get a letter in the mail that says you've been kicked off because we sent it to you and you didn't fill out the paperwork, that sort of thing. But this issue sort of came to mind. I don't really typically delve too much into like specifics of rural, but the reality of hospital closures is something that has been really a strong piece of advocacy for that organization because it has severely, severely impacted the clients of the organization, and related to that Medicaid expansion. And so it's something that I've sort of learned a lot about in my role in that organization, and then something that I really felt like as a Tennessean is specifically impacting us. So Tennessee, since 2010, has had 16 hospital closures. That is second only in sheer number to Texas at 21 since 2010. But on a per capita basis, like the population of Tennessee is about 6 million. There are 4 million just uninsured people in Texas, so to give you a sense as to like this population size of Texas versus the population size of Tennessee. So when you think about the number of hospitals that have closed in Tennessee, we're only 5 less than the state of Texas, and you can probably fit like 5 Tennessees in the state of Texas. So it's really impactful in our state. I think for sure the lack of Medicaid expansion is exacerbating it, and I think that that's true throughout the Southeast. So that's sort of what got me going on this idea. So we've seen this statistic, right? So in 2019, with 19 closures, we had 20 in 2020. But at the time, this was the highest, single worst year of rural hospital closure crisis. And it just seems to be going up. What we learned earlier today, right, is that is disproportionately in expansion, in non-expansion states versus in expansion states. And in addition to sort of some of the access issues that have already been discussed, one of the other things that's really impactful about the hospital is the hospital as community support, right? So the American Hospital Association says that for every dollar of money spent by the hospital, they support $2.30 of business activity for every dollar that the hospital spends. And the idea behind that is that the hospital employs individuals, a large percentage of individuals typically in a community, that those employed individuals then go out and spend money in the community. That promotes small business in the community. Those small businesses then bring back tax dollars and other tax revenues into the community itself. And it is a support system for the community as a whole. It attracts big business. Other big businesses might not want to come in, or even small businesses might not want to come in if you're telling people in the community that you have to drive 60, 70 miles to a hospital, especially when you think about a type of business that might have workers' compensation issues, like a warehouse business, or something that might involve the potential for injury. So the idea that the hospital leaves is not only an access issue, but it's just a straight up sort of community support issue. Jellicoe, Tennessee, actually, ironically, I looked at the Wikipedia page last night. The Wikipedia page in the sort of employment section said that Jellicoe Community Hospital is the largest employer in the city at 350 employees. And so now there are no employees at the hospital. So that kind of gives you a sense as to the importance of these in the community. So there's a quote from Carolyn Bruce, who was then CEO, she's since retired, of Western Healthcare Alliance in Grand Junction, Colorado, who said, "Decreasing services or closing a hospital stunts growth. Companies are rarely attracted to relocate to a community with little or no health care. Existing businesses may be forced to close or move out of the community. The rest of the community, health-wise and economically, can enter a downward spiral of decline." So beyond access, the importance of the community hospital presents something that is sort of unique and independent of just trying to meet the healthcare needs, but also just trying to meet sort of the community economic support needs. So we've seen this, interestingly, so these colors, I like hit copy image, and then I put it in where you can put into PowerPoint so that it like matches your scheme, right? So I did this, and these colors came up, which I think was a helpful tool. So Oklahoma, I think if you notice on Professor Buck's map, it was just like sort of the yellow and the blue, and Oklahoma, Missouri, and Nebraska were all in the standard blue and not yellow. This actually gives you the nuance that Nebraska and Missouri and Oklahoma are all very, very recent to the Medicaid expansion adoption. So Oklahoma is the most recent. They adopted Medicaid expansion through voter initiative, and I think just went effective, I think January 1, 2022, or if not, just like within the last few months. Nebraska and Missouri within 2021. So these are new to the Medicaid expansion map, but you can see, and we've seen this map before, that we're predominantly in the Southeast, Texas, and then sort of South Dakota, Wyoming, and Kansas. And we're down to 12, and I'll kind of give you a little bit of information about some of the details of those. One of the things that's really important for purposes of focusing on Medicaid expansion as a solution here is the idea of what we're talking about and who is impacted. So there was a mention of the coverage gap, and this gives you a visual as to what the coverage gap really is, right? So the coverage gap, as was explained earlier, was created on the basis that when the ACA was enacted, everyone was supposed to expand their Medicaid population. And so every single person who was below 138% of the poverty level was supposed to be automatically eligible for your Medicaid program. So the way it worked then is there was some wiggle room if you were above 100% of the poverty line, but below 138% of the poverty line, you could choose whether you wanted to go purchase insurance on healthcare.gov in the marketplace, or you were eligible for Medicaid expansion. If you were below 100% of the federal poverty level, there was no option. The idea was you were supposed to be in your Medicaid expansion population. Therefore, there is no ability to go on to healthcare.gov and purchase insurance with any subsidies. So if somebody who is earning 95% of the federal poverty level goes on to healthcare.gov, they can purchase insurance. The problem is that the price that they will have to pay would be even more than somebody who is earning 150% of the federal poverty level or 395% of the federal poverty level, right? Because those people are eligible for subsidies on the exchange. And so when we talk about the coverage gap and who's sort of left in this expansion and why, like what Medicaid expansion is really doing or not doing for individuals in the community, we've got basically everyone who's at 100% of the federal poverty level and below who has no ability to go on to healthcare.gov and access subsidies. In most of those states, there could be, so those two like blue figures, are individuals who have children. And so in some states, so like in the state of Tennessee, there is some coverage for individuals who have dependent children under the Medicaid program. Tennessee's is actually relatively generous, I think, at the 40% federal poverty level. Like it says 41% federal poverty level, $8,900 for parents, a family of 3. Not all states are that generous. Some provide 0, even if you're a parent of dependent children. Alabama is like 17%. So if you live at 17% of the federal poverty level, that's the trigger. You have to be below 17% of the federal poverty level in order for you to have access to Medicaid with dependent children who are on Medicaid, who are eligible for Medicaid. So this is a pretty large swath of the population. If you're talking about just 100% of the federal poverty level and below, we're talking 2.2 million people. If you add in the individuals for whom they could have Medicaid expansion, are technically eligible for marketplace subsidies, but for whom those subsidies are probably still not covering enough such that they can afford Medicaid, you're closer to about 4 million people. So there's a pretty big impact on the number of people who have been left in the gap by virtue of the fact that just these 12 states, and like I said, kind of Wisconsin aside, so these like 11 states have chosen to do nothing with their Medicaid program in terms of expanding to that expansion population. This just shows us, predominantly in the South, so 97% of this Medicaid expansion population is in the South, 3% in the Midwest, 1%, less than 1% in the West, which I think is only Wyoming is the only state that qualifies as West. It is disproportionately in Texas, Florida, Georgia, and North Carolina, right? So Texas is 35% of the coverage gap. Florida is 19% of the coverage gap, and then Georgia's 12%, and North Carolina is at 10%. The other non-expansion states make up about 24% by population. So when I talk about solutions and when I talk about whether or not there might be programs that are, or states that are interested in expanding their population and reacting to the American Rescue Plan or potentially reacting to Build Back Better, what we're really hoping for is Texas, right? At 35%, that would be the biggest swath. I will tell you that you're not, probably are not surprised by this, but Texas seems to have little interest in any of these programs. So that's another sort of trick, is that that because of this statistic, right, that 75% of this coverage gap is focused just on these 4 states, it's really also important to kind of look at those 4 states specifically to see their reaction to some of these proposals. So this is just sort of by the numbers. Hospital closures between 2013 to 2017. So this is kind of post-ACA through 2017, where there was kind of a lull in expansion. So in expansion states, we had Kentucky at the highest, which kind of builds on some information that it seems to be struggling more so in Appalachia than in other areas of the country. But California 2, Arizona 1, Nevada 1, Massachusetts 1, Illinois, and Ohio. The non-expansion states, by contrast, now I've got some stars by several of these states. Those are states that by the time we are now today sitting, 2021, 2022, those states have since expanded, primarily through ballot initiative, and I'll talk about that. But this kind of gives you some statistics as to the much, much larger numbers going on in these non-expansion states at a time when, since 2014, all of these states could have had Medicaid expansion. This is the 2020-2022 outlook. As was mentioned, the last 2 years have been bolstered substantially. So 2021 and then into this first month, bolstered substantially by federal dollars coming in through 3 different stimulus bills as related to the COVID pandemic. West Virginia appears on here twice. So Bluefield Regional Medical Center and Williamson Memorial Hospital are 2 hospitals that closed in 2020 in West Virginia. There are 20 total hospital closures in 2020. And the ones that are highlighted are those ones that are in our non-expansion states. So there is also a star by Missouri and a star by Nebraska. Those are 2 states that have enacted Medicaid expansion since the time that they had not expanded at the time of the closure, but have since enacted Medicaid expansion. So what's being done? Like, what are the, and I don't know what exactly time I started, so if I start drowning, just cut me off. What are the plans? So the American Rescue Plan has been mentioned, and by and large, the idea was, okay, we've got all these statistics, right? We know all this information. We have had years of study. Every single study that we talk about, just similar to the statistics that were presented earlier, tells us that Medicaid expansion is helpful for rural hospitals because some money is better than no money, right? So when you have individuals who come into the hospital and have some coverage, that even though Medicaid might pay 60 cents on the dollar, 60 cents on the dollar is better than 0 cents on the dollar. And that Medicaid expansion is helps to bolster these states once they have expanded the population. So knowing that, part of the American Rescue Plan Act of 2021, which is basically just a COVID-19 stimulus bill, is this extra 5% bump, right? An extra 5% bump that is provided for states to encourage and incentivize states to expand their Medicaid population. There are 2 states that have access to the funds. Missouri and Nebraska on the basis that they have expanded their Medicaid population in time to be able to access the funds. And it was done by voter initiative, sort of independent of, it was not in reaction to the American Rescue Plan Act of 2021. Missouri, interestingly, they had enacted a voter initiative, a ballot-led initiative to enact Medicaid expansion that went to the courts. So I think theirs was in 2020. It went through the court system. The Supreme Court actually just in Missouri recently said you have to expand. They took their first enrollment in October of 2021 and retro-dated all of the enrollment to July 1st, 2021, which enabled them to have access to the full funding for the 2 years that was available for the American Rescue Plan. So specifically for the money. As we're going forward, though, our 11 states that we're really focused on seem to be doing very little in reaction to the American Rescue Plan, and it doesn't seem like that there was like a huge, oh my gosh, did you hear about this extra cash that was in reaction to the American Rescue Plan? And I'll talk a little bit about why. But so it's out there. There is talk, there is notice in in Congress and the federal government and at the agency level, the executive level, that Medicaid expansion is important for rural populations, it's important for rural hospitals, and efforts to try and do things to bolster that, but whether or not these incentives are enough is sort of the real question. So there's also some efforts to encourage expansion in the Build Back Better Act. So the Build Back Better Act is currently floating through Congress. It's not clear whether it will be enacted, and even if it is enacted, what's not clear is if these particular provisions will survive, right? So part of what is likely to happen with Build Back Better Act, if it passes, is that it will go through a culling where some of the financial incentives that are in there need to be removed, because right now the biggest criticism of Build Back Better is it's too expensive. That there's too much money in it and that there's not enough sort of federal dollars to be able to support this large plan. In there, in terms of efforts to encourage expansion, is a provision that basically enables the states to, it kind of focuses a little bit more on a different policy. So it doesn't actually offer money to the states that currently haven't expanded. It says that there will be a federal option and that the federal government will fund at 100% the coverage gap population to purchase insurance on the exchange. So basically create subsidies and credits that are otherwise available on the exchange for the expansion population. They'll get funded at 100% and be able to go on to healthcare.gov and purchase insurance, private insurance. You can probably see, and maybe your question now in your head is thinking, okay, how do I feel about that if I'm a state that, as a state in West Virginia that has already enacted Medicaid expansion? Are you screwing me over? Should I just drop my Medicaid expansion plan and let you, federal government, give my otherwise coverage gap population 100% funding? Then the state doesn't have to pay the 10% that they're currently paying for their Medicaid expansion population. And just let you give them money and buy insurance on the exchange. So there's a provision in there to try and prevent that from happening, where they say, okay, well, if you already have an expansion population, instead of giving you the 90%, we'll give you 93%. So we'll up our matching that we're currently giving you from a 90% match to a 93% match. It's only in the bill for 5 years. So it's like a five-year 93% match. My guess on why 93 versus like maybe 95 or something like that is just, it's already crazy expensive, right? There's already so much money in this bill that probably that was the compromise as to what would be appropriate. But again, what we're seeing is that the focus is incentives. And And I'm going to talk a little bit about why that is. So what is the likelihood of success, right? What's the odds of this really happening? What are the odds of this being successful? What are the odds of getting these final 11 states to a point at which they're expanding their Medicaid population? And what I'm going to tell you is that there is an increasingly narrowing landscape for Medicaid expansion. So let's talk for a second about how Medicaid has expanded so far. 28 states adopted it like out of the gate, right? So January 1, 2014, or by the end of 2014. So by January 1st, 2015, 28 states had adopted Medicaid expansion from the get, like saying, yes, we will go ahead and do this. We think this is good for our population. 18 of those had Democratic governors, 10 had Republican governors. So it was a little sort of bipartisan at the beginning, a little bit more slanted towards Democratic governors versus Republican governors. 6 of those were through a Section 1115 waiver. So 6 of those 10 Republicans were actually through a Section 1115 waiver. And what that means is that instead of just saying, okay, we'll take the money and we'll add them to our Medicaid program, they went in with some bargaining chips. So we heard about, like, there's a lot of leverage and a lot of negotiation. I'm not going to run Medicaid the way you want me to run Medicaid. I'm going to run Medicaid the way I want to run Medicaid. In those were a lot of work requirements and a lot of other limiting factors that actually created more limitations on the population and the population's access to Medicaid. So for certain states, they used expansion for purposes of trying to do other things that would otherwise restrict or limit their Medicaid population. So we saw, we're not seeing necessarily that it was just straight up adoption, expansion, or expansion adoption, but that there was some sort of bargaining with that going on. There were only 4 states that adopted Medicaid expansion between 2015 and 2016. So we were up to 32, but there were some states that were sort of still thoughtful about it and then enacted after that. 3 of those 4 were through executive authority only. So what that means is that the governor, through the governor's own executive authority, without the role of the legislature, went ahead, put it in the budget, and passed Medicaid expansion. That's not necessarily possible in all states. So in Tennessee, there was talk of Governor Haslam at the time who wanted to, he said he was going to enter into Section 1115 waiver discussions with CMS. He was going to propose what would be called Insure Tennessee, which was something that he was not calling Medicaid expansion, but would be kind of Medicaid expansion. He had gone pretty far down the trail of negotiating it with CMS. The legislature immediately reacted and enacted a law that said that the governor could not act without the bicameral support of the legislature. Both Senate and House would have to approve any plans that he proposed, which basically shut the entire discussion down in Tennessee, because now there can be no Medicaid expansion without support of both houses of the legislature and the governor before it could be passed. So there have been 6 states since 2019. So there were no states between 2016 and 2019. There have been 6 states since 2019. 5 of the 6 are through statewide ballot. So you can see, as we're coming into Medicaid expansion, the window for how we are enacting it is getting narrower and narrower and narrower. And I will say, I should have mentioned at the top, I do think that some of what was going on made a little bit of sense at the time. Like in 2014, and I'll talk politics a little bit here, for Republican-led states, I think that there was a genuine belief on the GOP side and for Republican governors that the ACA was not here to stay, right? That this was going to be sort of an immediate repeal and replace, that we would get midterm people in there and that they would replace the act. Do not waste your money, right? Do not go and spend a bunch of money trying to expand your Medicaid population and adding to your program, because the second that we repeal the ACA, all of this is going to go away. And so that's sort of what led to some of the stagnation in 2015, and then we now, I think at this point, just have entrenchment. Right, that we've gone this long, we've done this thing, we haven't, we're just, this is how we're doing it. So the 506 of these last 6 states are through statewide ballot. That gets us to our current number. The statewide ballot process is only possible in 3 of the remaining 12 states. So South Dakota, which currently has a ballot initiative, like I think both a ballot initiative for the Constitution and then one for this by state statute that would expand the Medicaid population. Florida, which seems a little dicier in terms of the ability to even get it on the ballot, and in Wyoming. Those are the only 3 states where it's even possible to have a ballot initiative. It is not possible to take this to the voters in the other states. All of the legislatures in these states are Republican-controlled. 10 of the 12, I shouldn't say 10 or 12, 10 of 12, have a Republican governor. So North Carolina and Kansas are the only 2 states that don't have a Republican governor as well. Statistics point to the fact that if you have Republican-controlled legislature and Republican governor, there's an 8% chance of passing Medicaid expansion. Unfortunately, I don't have necessarily a lot of hope that expansion in our sort of window as to passing is something that might be very likely. So the next question sort of led me to, well, what are the odds of these new incentives working, right? This is like the landscape of like, if we just do nothing today, what are the odds of us like just sort of organically keep kind of trudging along and hope that states think about it? And I would say it's probably very, very, very narrow. And that like, so in Kansas and in North Carolina, the Democratic governor has put it in the budget the last 2 years. The legislature hasn't approved it in the budget, but that's kind of what's going on. The status of the ARPA, no non-expansion states have yet adopted it. Like I said, the 2 states that are really using it are states that had already adopted via statewide ballot and have access to the money because of that. The Texas legislature did propose a bill in 2021, but it failed to pass. South Dakota has 2 potential ballot initiatives, so that's the one thing that's helpful. And Kansas and North Carolina have money proposed in the budget. By and large, most of the other reaction has been, oh, that's really interesting, that's nice, we'll look into it. And there's been very little actual sort of reaction to that. I'm not sure that ARPA is going to be a silver bullet or sort of anything that people start taking up in rapid, with sort of excitement. Also, the timeline is dwindling, right? The money was only available for 2 years. That time has already passed for at least 7 months because it was July of last year. So the longer people wait, the less money is available, which makes the incentives less enticing. Build Back Better, I mean, I hesitate to even talk about Build Back Better Act because it's not even passed yet. So first you have to get through the hurdle of passing this bill, which has all kinds of other sort of independent, unrelated to this provision, right, things that are going on that are outside my talk. But I do think it faces political challenges unrelated to Medicaid expansion. It's unclear whether these incentives will be enticing, right? I mean, I think there is some danger that you might have some of the expansion states that went a little bit kicking and screaming. Ohio, Maine, there's a few states that, Ohio specifically, like, it was very contentious. Governor Kasich passed it, and his legislature really did not like it a lot. So it could be really risky for other states to just drop their Medicaid expansion program. So that's a lot of fear, I think, with the Build Back Better Act, that it might have inverse incentives. The other thing that's really important to think about is what the Build Back Better Act is doing. And it is encouraging individuals to purchase insurance on the marketplace. And there could be benefits to hospitals. Like I was talking about this yesterday with Professor Buck, actually, and I feel a little bit conflicted about this one in the sense that if what we do is tell people to purchase insurance on the exchange versus get their Medicaid their state Medicaid program, from a hospital perspective, I might actually want the commercial insurance payer as opposed to the Medicaid payer, because there might be more money there. The problem from the consumer perspective, right, so from the individual perspective, is I probably have better benefits and coverage and less cost-sharing obligations under my Medicaid plan. So there's some real risk in putting people to the marketplace because those plans are costlier. Marketplace plans also have significantly narrower networks that are available. So oftentimes people will purchase the cheapest policy and don't realize that it has an exceedingly narrow network, which means we get hit with things complicating like the No Surprises Act and surprise medical bills. Ground ambulance transportation makes me really, really nervous in rural healthcare communities because that's specifically carved out of the No Surprises Act. So if that ambulance shows up at your home and then drives you 40 miles to the closest hospital, you're going to get a bill and it is out of network and they don't have to tell you about it and it's going to be very, very expensive. And so I do worry a little bit about that from a consumer perspective, that also the product that might be purchased by these coverage gap individuals is not the same product as if they were able to get onto their Medicaid plan. A lot of states have, I think we're going to hear about dental later today. Jackie's going to talk about dental. A lot of state Medicaid programs have dental coverage. Your commercial insurance plans will not have dental coverage, so there's just some different variables there. And so the last thing I'll mention is just incentives versus penalties. I'm just not sure incentives are working. There is ample evidence that economically there is plenty of reasons why states should pass this, and it is beneficial for the state's revenue, the state's population, the state's economy, communities, that is independent of like extra money that is being thrown at them from the federal government, and none of that has been enticing to states. So a little bit extra money, I think, is also not giving them enough incentive to sort of to boost. The economic, what's known as the multiplier effect, benefits to rural hospitals and rural communities has been long demonstrated for the last like almost decade since the ACA went into effect, but it's just not enough to sway non-expansion states already, so I just question whether incentives are really the answer. The other thing to think about is the reason that we're seeing so many incentives is that NFIB versus Sebelius makes really anything other than incentives legally difficult. So NFIB versus Sebelius, I think everybody probably has read the case. You can't do something that is coercive to the other states. What would probably be the easiest way to encourage these states to expand their Medicaid population is to apply penalties associated with the federal matching that they're getting for their Medicaid population in general, right? Their general Medicaid population. We can't do it under NFIB, which is why we're seeing all of these incentive programs as opposed to something that might, right? There's always in the law, carrots and the stick, the carrot and the stick. If the carrot doesn't work, we have to apply this. The problem is that we only have carrots, right? That the legal structure and landscape has given us carrots only. So it's just challenging to assess these penalties outside existing Medicaid programs. Nevertheless, my hope for the end of the day, my article does say that I do really think federal efforts should continue, because I do think that the evidence is clear that Medicaid expansion does do the best to bolster support for rural hospitals and stem rural hospital closures. And so there has to be some means or mechanism that we use for purposes of continuing to get individuals in rural communities coverage that they need, because that ultimately supports communities, which supports the community at large. And that I think that the time to do it is now, because these rural hospitals have been shored up through COVID relief funds, and we're likely to see a rapid descent if we don't tackle it immediately. So that's it.
I think we have time for a few questions. Jared?
Yeah, thank you for coming again, by the way. I loved it. So you and Professor Buck both highlighted how the most recent expansions have been by, voter initiatives, more than likely, and they're at least nationally in red states. What does that say about maybe the voters in the state's view of healthcare, like partisan or nonpartisan, versus like legislature's view of healthcare as a partisan issue?
Yeah, I do. I think that's exactly right. I do think that legislatures see healthcare in a partisan way that individuals do not. I mean, Tennessee Justice Center runs all of these polls and things like that. And I mean, when Insure Tennessee was being proposed, and now when they poll the state, almost 3/4 of the state is supportive of the idea of expanding the Medicaid population and creating greater access. And so I think that when people are living in communities and know how important healthcare coverage is and just want any coverage at all, they don't see it as sort of political as everyone else. And I don't know how to divorce that for the politicians to just try and convince them that this really isn't about politics. And when I talk to my health law class a lot, and I say, this didn't used to be a controversial class. Health law usually, historically, was not something very controversial at all, and has now become sort of politically charged. But at the end of the day, what people are fighting about is not really should we have it, but who's paying for it. And if we can maybe kind of keep it focused on that, like who should pay for it, then maybe it kind of helps divide it about like whose camp we're in. But I totally agree. It does seem like it has become very, very political, but only for those in elected positions. And that by and large, when they poll the US, they're mostly want access to care. They want to be able to have something be affordable for them, whatever means is necessary in order to get that, whether it's through employer-sponsored, through insurance subsidies, through Medicaid. Most often people don't care, they just want some coverage.
Thank you. Anybody else?
Thank you. This was such a great talk. So going off of Jared's great question, do you think there are lessons? I won't speak for any of the other health law people in the room, but I will say I think we've sort of reached the end of what the Affordable Care Act can do, and there are still problems with the system. And so,
Yeah.
The next conversation is what do we do? What do we do now? And the Affordable Care Act is a very technocratic, incremental shift that didn't deconstruct our broken system. It just sort of tweaked various pieces of it. And so I guess what I would ask you is are there lessons from this for sort of the next wave of big health reform and what that might look like?
Yeah, I think I'm in agreement with Professor Buck that I think that probably we just need to think about it differently, right? I mean, these solutions are just like, let's throw more money at it. I think one question for me, and I know that a lot of the proposals out there are basically whether or not we should be, whether we should ask the question, after I've just told you how important hospitals are to the community, ask the question about whether every community needs a hospital. And I should say, it's not that I don't think that Jellicoe Community that city might need a hospital. Maybe they need a clinic. Maybe they need an emergency room with sort of clinic access. Maybe we need to rethink that structure. Maybe we're trying to do too much in too many places. And I think some of that is we've gotten so sort of fixated on this model of providers, and like this provider does this and this provider does that, and our regulations have cemented that, right? That like with conditions of participation and with licensure and with all of these other regulations that we've come to sort of define we need these things and these things. And I think one of the next big healthcare reform pieces needs to be we probably need to reimagine the system. Like, what does access mean? And what do we need access to? And so what are the important pieces of access that need to be bolstered and provided and supported? And what are the things probably that are weighing down that aren't sustainable? And that maybe there does need to be a sort of reckoning with some of the models we're creating we can't fix. Like, we can't fix it. They're just, as there's changing demographics in rural America. There's less population that's staying in rural America. Individuals that are in rural populations tend to be elderly, like more elderly than urban populations. So there's some fundamental sort of shifting of the dynamics of rural populations that I think also need to be more focused on to think through from a root cause analysis, what do we need? And we're not really asking that question. We're just sort of like putting the Band-Aids on everything. And I know Medicaid expansion is that, but this is sort of my framework of like, if we're not doing anything, at least let's try and do this if we can. But at the same time, I think the real solution is we probably need to rethink it entirely, right? I think we need to focus on a different thought process of what are our needs and start there.
I think we have time for one more.
I can talk to Debbie offline too. So usually when we talk about these kind of things, like, students will be like, why in the world do we pay it in this weird way? And often the answer is like doctors wanted it that way and they lobbied. I mean, that's the cynical answer. But so I'm like puzzled and kind of marvel at the fact that hospitals have not gotten their way. Like I remember when I was a newbie law professor talking to my mentor about the structure of this, and people would say like, no, the hospitals in Atlanta and Nashville and Dallas will knock on the governor's office and say, you're gonna put us out of business. You're gonna make us shut down our services.
Yes.
And that will work because they get their way, because they contribute to the campaigns. So I guess what I'm interested in kind of your thoughts are is like, have you seen any explanation for why that didn't work this time?
Yeah, it's crazy. And that is very true. It just didn't work. Like I worked at Vanderbilt at the time. So I was in the Office of General Counsel, working for the medical center for about 9 years before going into teaching. And we lobbied pretty hard. Vanderbilt and the Tennessee Hospital Association, both large hospitals and small hospitals across the state saying, please do this. Like, these are the economics. Like, let's not think about this from a political perspective. Let's just put our finance hat on, and we can show you that financially this is smart for the state. Let's do it. They're throwing money at us. Let's take it. And if it goes away in 2020, we can rethink what happens in 2020. But for the next 6 years, let's take the cash. And somehow it didn't work. And I don't know, and I think, even with legislators who have hospitals that are closing in their counties and their constituents are complaining to them, and you have statistics that indicate that, these statewide ballot initiatives where clearly legislators are out of touch, it seems like we're getting it on all fronts. And I'm not sure. I'm not sure why it's not working this time. I don't know if it's saying something about the power of the hospitals and the providers is diminishing. Certainly, I think it's complicated from a state perspective because there's lobbying of increased funds from Medicare that seem to have always been successful at the federal level. Yeah, I don't know. It's baffling to me, especially just and I think it was baffling even at the time for hospital administrators who had always gotten their way, and we're like, wait, what? Like, you mean you're not going to listen to us and do whatever we want? Like, that can't be. And something that they felt like they had so clearly laid the case for, as to this is a slam dunk. Like, we're all in agreement. This is the best thing. And then, to be fair, I think they genuinely convinced the governor, in Tennessee anyways. And I think that's true in certain states. The problem is everything going on. And I don't know if it's just politics today. And it doesn't seem to be a winning argument when you go back home to your constituents, though, either. So I have no answer. Thanks so much.
Thank you so much, Professor Farringer. We are going to take a very short break. We're going to try to come back at 11 for Professor Fox, but take a minute. Thank you. Hello, hello. who made that plan? Like, I don't know who put me there.
Do you need anything? I'm good.
Could you grab me a water? Thank you. Superman is back. Yes, he is. You know me either, but it's only one word. I gotta grab my phone. Hey, Professor Fox, can you hear me?
I can. Can you hear me?
Yes, we can. All right, we're gonna get started at 11, so you have a
Okay.
few minutes.
Is this all right where I am right now in terms of the lighting
Yeah,
behind me?
that's perfect.
Okay, great.
All right, thank you.
All right, I'll see you in a bit. You just shout and I'll turn on the video, okay?
Okay, sounds good.
All right, thank you.
All right, we're going to go ahead and get started with Professor Jacqueline Fox. Let me go ahead and, there we go. Professor Jacqueline Fox is a professor of law at the University of South Carolina School of Law. Her scholarship focuses on health law, healthcare financing and regulation, and healthcare reform. Today, she will be presenting her article titled Dental Care in Rural Populations and Medicare Coverage. Please give her a warm welcome.
Hey all, can everybody hear me? Yes. All right, awesome. Okay, so thank you all so much for having me here. It's been wonderful to watch the other speakers. I've been enjoying this a lot. As I think Zach mentioned, COVID's been rough, right, on having those communities where we get together and talk about this. And I think when you're a little obsessed with healthcare financing, you don't have a lot of safe spaces to really just go off about that sort of thing without chasing other people out of the room. So this has been really nice to listen to. When I started this project, when the law review first sent around this awesome idea for the symposium, what I thought I was going to be writing about was an expansion of Medicare to include dental coverage. And, you know, in the Build Back Better law, there was a proposal for it. And my thought was, well, this is a great step. And then it didn't happen. And so I had all these thoughts about what, you know, we could do to make it even better, to build on it, et cetera. And then when it didn't happen, I thought, well, now, you know, I could still do an examination of what's going on in rural areas with dental care for older populations and what we need to do and what the problems are. And so I started to pull that together, just trying to sort of do a state of the country kind of thing, like what is happening with older populations in rural areas. And I have to tell you, it was troubling. And, you know, a number of the speakers today have talked about what do we do? How do we look at our system? What is necessary now? And I have to tell you, I'm at a burn it all down point from looking at this. And let me explain why. I want you to think about who has suffered worst under COVID as I go through all the data I'm about to hit you with, because I've written about dental care before, okay? And I am really familiar with the arguments about what we need to do, about incremental change, about how we create incentive structures, about who the stakeholders are, what the goals are. And they're very specific, they're very granular. They're about getting into communities and working on incremental change and financing and things. But then when the same people are suffering in the same exact way, with dental problems and with COVID deaths and long-term COVID and things like that, you have to start wondering, is this really about the specific granular issues we're pointing at, or is this about us? And you know, who we believe matters. So with that, I want to launch into this. Dental care is really weird for people who haven't really thought about it a lot, okay? Because it is so huge and so important and so cost effective that once you dive into the specifics of it, it's kind of stunning that we don't just automatically provide required dental care to everybody just freely, okay? It's that obvious. Let me give you an example. It's actually less expensive to provide basic cleanings and maintenance for people's teeth than it is to not. Like even not taking into account spillover effects or whatever, like in a Medicaid plan that doesn't cover dental coverage, that just covers emergency medical infections, not covering dental care costs them money because people show up in emergency departments with abscesses coming from untreated dental problems. They have to fix those. They don't have a funding stream to actually fix the underlying problem. So they give them antibiotics and bring the infection down, flares up again. Then it costs billions of dollars to not provide dental care. So it's a weird question coming in. Excuse me. Okay. So what am I talking about with dental care? I'm talking about primarily dental cavities and like gum infections. They're almost entirely preventable, and 91% of all adults will suffer something from both of those issues. Oral health problems lead to tooth abscesses. They lead to oral cancers. They lead to 7,500 deaths from oral cancers from late diagnosis every year. But there are also strong associations between poor oral health care and increased risks of stroke, of heart disease, asthma, diabetes, and even increased risk of cognitive decline in old age. It's also likely that untreated and persistent dental pain, which affects a shockingly large percentage of the population, by the way, is leading to opioid abuse, because a lot of people start using opioids in an effort to self-treat this sort of persistent pain. And dental pain is really bad. I don't know if anyone here has ever actually experienced it, but it's not the kind of thing that you can ignore or readjust how you sit so that you're more physically comfortable with it. It's a sort of overwhelming kind of pain. And so people reach to any kind of numbing agent they can to control it. There are other problems with untreated dental problems and with people not getting access to the appropriate dental care. It leads to increased risk of obesity because people have trouble eating good food when their teeth hurt. They don't get the right kind of calories. They tend to go for much more processed food because it's softer and easier to consume. It leads to social stigma. Missing teeth actually make it harder to get employed. They make it harder to get advances in employment. People are very uncomfortable when they're not comfortable smiling, particularly women. Women take a much bigger financial ding when they don't have all of their front teeth than men do. And it also leads to learning disabilities, which I've written an article about earlier about children suffering from dental care, because when they're in this persistent pain and when they can't eat well and when they miss school because of dental pain, it makes it much more difficult to concentrate. There are a lot of studies that were done about the effects of pain, like in cancer situations and things like that with children, showing reduced cognitive abilities when they're struggling to control pain, and dental pain actually has that same sort of effect on them. All right, so where are we in terms of rural communities? So all of this is worse in rural communities, all right? And it's even worse for lower income people in rural communities. And then it's even worse for less educated people in rural communities, and add to that people of color within these rural communities. So again, remember what I was saying about COVID, like who is suffering most from COVID, and think about that in terms of who's getting to see a dentist. Look at it this way, like in any given year, for example, when you look at who has gotten in to see a dentist, right? White women, 40% of them haven't seen a dentist in a given year, like for elderly white women, right? For white men, it's 44% haven't seen a dentist in any given year. For Black women, it's 64% haven't seen a dentist. For Black men, it's 74%. For people whose income is less than $10,000 a year, 73% don't see a dentist in any given year. For people whose income is over $40,000 a year, 25% haven't seen a dentist. All of these numbers then are worsened when we're talking about rural areas as opposed to urban areas. And so what we're looking at are huge swaths of lower income, rural, uneducated people who just don't see dentists. Not surprisingly, an extraordinary percentage of them have none of their natural teeth left either. So it's a pretty bad situation. There are 5,869 dental health professional shortage areas. That's where the federal government steps in and tries to ascertain if there are enough care providers within these counties to actually provide the care that's required, even if you had the financing for it. Almost 60% of those are in rural areas. Before COVID, 42% of adults in rural areas didn't see a dentist at all in any given year. And that's compared to 33% of adults in cities. You know, you could say that professional shortages, like I was just talking about, the transportation issues, that lack of health insurance are all worse in rural areas, and that is why we're not seeing these patterns. There are also studies trying to look at whether education is a problem, that people don't understand that they need to see dentists regularly. But I think the main issue is that we simply haven't cared. We have advanced so much in what we understand will prevent all of these problems. We have advanced so much in what we understand will fix all of these problems, right? We know that people need to see a dentist twice a year. We know the kids need to get these sealants on their adult teeth when they come in to prevent them ever developing cavities. We know that the requirement of cleaning your teeth and jumping in and addressing like decay and stuff like that is super important to do quickly so that we don't develop all these problems in our teeth. We know that keeping your natural teeth actually really reduces the risk of a lot of other infections that people have across their lifespan. Because bacteria gets in where the teeth are missing and creates an inflammatory process that does lead to the heightened risk of all those diseases I was talking about. It's not weird that West Virginia, for example, has the highest percentage of people in the country who don't have any of their natural teeth, and also has the highest percentage in the country of people with diabetes. Like, that's not confusing to researchers who are looking at these issues, that those two things go hand in hand, right? Because they're related. The teeth are in the body, right? The question of who has no teeth, though, so I said that West Virginia is one of the leading ones with no teeth. I want to dig into that a little more for a second. 20% of rural elderly in the country have no teeth, and 14% of non-rural elderly have no teeth. And the number has been actually improving nationwide, right? And trying to keep elderly people to have all their teeth as they get older. But the improvements have been entirely in urban areas. So the rural areas have had absolutely none of that improvement. In West Virginia, 25% of elderly across the state have no teeth, which is the highest rate in the country. But there are counties, individual counties, that have much, much higher rates. An example, leaving West Virginia, not just to pick on them, in Louisiana, like in a rural county in Louisiana, such as East Carroll Parish, 40% of the elderly in a typical county would have no teeth. That's a lot of people. That's not even including the people who only have 2 or 3 of their natural teeth left, right? Which is much more common. Something like 96% of elderly people have some form of gum disease right now across the board in the country. I mean, it's hard to come and just say we're doing a catastrophically bad job of this, okay? But I just have to start with that up front. So Medicare doesn't cover dental care. And very few people keep dental insurance after they retire. So we started with a really big gap in terms of that. And we know that when people have dental insurance, nationwide, they tend to have better access to preventive dental care, because most dental insurance just covers basic amounts for dental preventive care. But many Medicare Advantage plans do have dental coverage. The Kaiser Family Foundation did a really good study of all of this, so trying to really dig into dental coverage and its effect on care when the Build Back Better Act was proposed, because they were trying to get some data to help guide the debate about it. And what they found is that half of all Medicare beneficiaries don't have any kind of dental coverage, and that, remember those numbers I was talking about elderly who never see a dentist, right? Like, what a big proportion of all of elderly that is in any given year. So even with that, if you average across all of the elderly, they're spending around $875 a year a piece on dental care. So what that means is, if you look at the ones who actually are getting access to care and realize that a lot of them have some dental coverage, and the average across all of them is $874 a year out of pocket per person, you know that the people who are spending money on dental care are spending a tremendous amount of money on dental care. Does that make sense? Because you're pulling all those other people out of the numbers. And not surprisingly, 20% of elderly populations spend well over $1,000 out of pocket in any given year on dental care. So what it seems to be is either you're not going to the dentist, or you're going to the dentist and spending a ton of money. Seems to be the kind of split with this. When you look at these Medicare Advantage plans, the question becomes, are they good enough? Do they work? And in rural areas, very often they simply don't. And that's because we don't have the providers there. But the other problem that they have with Medicare Advantage plans is that they tend to cap the amounts that they pay. Most of us who have dental insurance are familiar with this, because most of our dental insurance also has a cap. It might be $1,000 or $1,500 in any given year. And it tends to have very specific amounts that it'll pay for things like crowns and things like that. And it's very easy to max it out. So you do end up spending a lot out of pocket. What's useful about them, again, is cleanings, dealing with abscesses, things like that. But let's look at Medicaid, since we've been talking a lot about Medicaid here and the role Medicaid could play in this. Most states that have Medicaid are moving towards having some coverage for adults who are in the Medicaid population for dental care. And then the reason for this is because of that problem with the abscesses that I was talking about, that it will save them a tremendous amount of money every year to have the coverage as opposed to not having the coverage. And also because it helps with the non-elderly adults in the Medicaid population, having dental coverage significantly increases employment rates for women in particular on the Medicaid plan, as I was saying, because women, well, they have to smile a lot of the time to get jobs and things like that. And so there's a direct connection between protecting their teeth and having them get jobs and be able to work. But the Medicaid dental coverage for adults varies wildly, and it's very sensitive to financial stresses on the states. Because the federal government, it's not like they pay for the Medicaid programs to cover the dental care. They do some contribution, like they do with every other bit of Medicaid coverage. But this state budgets tend to be, they can't spend into debt, right? The way most state budgets are constructed, like the federal government can. And so when they're hit with budget shortfalls, they tend to cut the Medicaid dental coverage first. And so what you find are patterns of like, we'll cover it, then we scale it back, then we cover it maybe a little bit more because we realize it's money saving, but we're hit, we need to cut the budget, we scale it back, et cetera. And there are a lot of proposals saying that, you know, the federal government should increase their contributions to state Medicaid programs to ensure that dental coverage for adults is more robust and more consistent, because the payoff is so immediate in terms of cost savings and improved health. But so far that hasn't happened. There were a lot of hopes that that would happen in the COVID relief bills that occurred, because it's just, again, it's cost saving. It's a net savings across the board, but it hasn't done it. None of the plans that I'm talking about, the private insurance that comes from employers, Medicare Advantage plans, Medicaid plans, Medicaid Advantage plans, none of those things include what I would call top tier care. And that would be something like you're losing a tooth, and so you get an implant so that you have basically a functioning tooth in there, a dental implant. None of them cover that. What they cover are dentures. So, and they tend to cover one set of dentures a year at a relatively low rate. So what we're talking about are people who will get their teeth pulled to prevent the problem and then just have these false teeth put in as a way of caring for it, which does not prevent the kind of association with diabetes and things that I talked about before from having the missing teeth. There is some hope that implants do help prevent that because they stop the easy flow of bacteria through the exposures, but the dentures don't do that. Now, that's all grim, right? So what have I set up? I've set up a situation where the older you get, the less likely that you're gonna have access to dental care, right? And the older you get, the more likely you're gonna have dental problems. I've set up a system where the effects of a lifetime of poor dental care are most heavily felt by the elderly, right? Through these high rates of diabetes and heart problems and things like that that are in the elderly population. Let's make it a little bit worse, right? It's actually harder to provide the kind of dental care that elderly people need than it is to, for example, provide the care that children need. Elderly people are on a lot of medication as a population. They have advanced kinds of gum disease that are not as common in younger people. And you need special training and special abilities to be able to most effectively address these kinds of problems and vulnerabilities in elderly populations. So not only are we disproportionately not providing them any care they actually need and would get a huge benefit from really good, high quality care that's trained in elderly people. One thing I hadn't mentioned yet is disability and access to dental care. Those who are disabled have catastrophically low access to dental care. And now it depends on the degree of disability. Certainly those who are disabled to the point that they have to live in residential facilities have almost no access to dental care at all. It's awful. And if you add to that the kind of medications people are taking that can lead to dry mouth and gum problems, it's many disabled people are just in chronic dental pain with decaying systems. It's very depressing to contemplate. And when you think of the number of elderly people who are living in nursing homes because they're disabled, and you add that kind of chronic dental pain and lack of access to that, it's a pretty miserable proposition. All right, so what can we do? What can we do to fix any of this? Okay, so there are some things we can do that start chipping away. First of all, we're doing a lot better in terms of providing preventive care to children. Medicaid itself covers dental care for children across the board. And some states even cover braces and things like that. Like we're actually doing better. And dentists are recognizing that they need to step up. We're doing more enhanced training of dental hygienists. We're setting up plans where they can be providing care in schools. We could be doing much better. A country such as New Zealand, for example, that has what are called dental therapists, which I'm going to discuss in a second, provide all of the dental care that children need in grade schools. They have dropped their dental decay and caries 100%. They have almost no problems in that entire population because they just get the proper preventive care when they need to. We could be doing that. We're not there yet, but we're doing better. And the spillover effect of that as these children age is that they will have much better dental health, when they're older people, but we're not there yet, right? So what could we do for the older people now? Certainly having Medicaid cover dental care for older people in every state is a no-brainer. And I think we're moving in that direction. States are adding dental coverage with every year. It's 5 or 6 states. I think we're up to almost 40 states now have some degree of coverage. So I'm hopeful that's going to happen. Increasing the federal matching funds for dental care to incentivize that is a really good idea, super cost effective, and will save, I think with the congressional budget calculations, I think it should save money. So that is something that should get bipartisan support. So let me talk about dental therapists for a second. Dental therapists are people who have training in cleaning teeth and diagnosing cavities and filling them and doing some degree of gum treatment. It's much shorter in training than to be a dentist, but it's more extensive than being a dental hygienist. These have been globally adopted with great success, and there was a tremendous amount of resistance to them in the United States. They started to be used in the early aughts for indigenous populations. It started in Alaska, and then other states that had a lot of reservations started using dental therapists to provide dental care there. But now it's gradually spreading. There's been some great developments in terms of creating accreditation standards. The federal government in 2018 recommended to states a series of law changes they thought would fix sort of blocks to implementing dental therapy training and funding programs. So I think it's gonna expand much more. I think there are 13 states plus some that allow it for indigenous populations that currently are allowing dental therapists to practice there, but it's exploding. And I want to talk about that for a sec. It's a great job. It's a great job for people to move solidly into the middle class without having to go into a lot of debt. It's really controlled working hours. It pays well. I mean, it's really good in every possible way. They tend to be better trained in pediatric dental care than dentists are. The outcomes with children using dental therapists are actually much better than outcomes with children using dentists, at least internationally. So it's a win-win. It's frustrating that we've been so slow to move in that direction, but it's really nice that we're starting to. Super cost effective. And, I'm hopeful that if we start moving towards dental therapists with some training in geriatric medicine, that we could really do a lot of the gap filling for rural populations that is required. Like, see, Medicaid tends to have really low reimbursement rates. Medicaid's the program, right, for poor people. Sorry, I should have explained that, but it was explained in a lot of the talks. And I think that the reimbursement rates are actually sufficient for dental therapists, even when they're not sufficient for dentists. And I think that if we could get dental therapists out in the community, like in these buses and things that deliver care, that satisfy a lot of the transportation problems, things like that, I think that financially we could do this, and then it could help solve a lot of these problems. So I'm hopeful in that way that we'll be doing better, right? So what am I saying? We're moving towards more dental therapists. We're gradually doing better with children's care. We're gradually expanding Medicaid. We messed up in expanding Medicare. It doesn't look like that's going to happen, but Medicare Advantage plans are stepping up to cover some of the dental care. So why am I depressed? And why do I come in and say, look at what happened with COVID and that maybe we need to do a totally better thing? We've known for decades, okay? We have known for decades exactly what is required to prevent all dental problems. Think about that for a second. Like, we just know what to do, and it's super easy to do it. And it's even in the narrowest possible sense of what's cost effective. It's been cost effective for decades. And we're not close to universal access. I mean, look at those numbers I was talking about, where 74% of Black men do not see a dentist in any given year. When you couple that with the fact that probably 30–40% of them are in some form of pain from their teeth, we're inhumane. We're just flat out inhumane. And we have been tolerating this for a really long time. And then I look at what happened with COVID, all right? And you know, with COVID, we were like, oh, some of these people are just more vulnerable, right? And maybe it's because you're obese. Maybe it's because you had diabetes. The way people would talk about people who died of COVID, they'd be like, oh, did they have vulnerabilities? And then they'd be like, oh, okay, I don't have to worry about it. There was this persistent othering and sort of sub-rosa eugenics kind of language that kept appearing, and how people were talking about who was suffering the worst effects of COVID. And there was this dehumanizing that I watched happen and was quite horrified by. But then I started to think about it. I was like, maybe this is us. Like, maybe the fact that a lot of people are suffering dental pain and are just being abandoned, and have been for decades, and they're the same people who suffer these COVID bad effects, maybe that's not a mystery. And you see it at the outer edges, where it's who is told to just go to work in person without really the protections they need with COVID, without us putting, HEPA filters in there and mandatory high-level masking and things like that I personally had when I was teaching in person, right? They're essential workers, but they're treated as disposable. Like the people in meat factories, for example, who just had such a high rate of COVID infections, right? We're told to keep going into work and keep working. I don't know. And maybe I'm wrong. And, maybe I'm curious to hear what you all think about this in the questions, but I feel like we need to do some serious thinking about this. Like, if our goal is a healthcare system that truly validates that all human beings are equally deserving of respect, that if our goal is justice and best outcomes across populations, we're not doing that. We've got people who are passionately fighting for it, who present in health policy pages and pages of data, right? Who try and work with stakeholders to help present reasons why this is a good use of scarce resources. I mean, they do this over and over again. But if you've got systems where it's obviously a slam dunk, good use of your resources, and the system still doesn't do it, maybe the problem is the system. Maybe it's how it's valuing people, and maybe health policy people, that we need to take a much more aggressive stance at calling this out. I don't know. I'm not sure, but I'm at a loss, to be frank, at this point. I'm still going to make my recommendations and hope for incremental gains, but this has been a sobering time. And that's about it. Thank you very much for listening.
Thank you so much for joining us, Professor Fox. I thought you did a great job of explaining the current crisis that dental care and access to it that America and rural America is facing. I think I can start off the questions. The first one that I was going to ask is, you did such a great job of explaining all the underlying medical problems that happen if you don't have proper dental care. But you also pointed out that many states with Medicare don't offer dental coverage, and then the ones that do, it's usually the first thing that goes when money gets tight. Do you think that there's some messaging problem with the importance of dental care? Do people view it as an aesthetic thing only, and maybe not as all these underlying health problems that you have pointed out?
It's a really good question. Okay, so first of all, it's Medicaid, just to be, and I should have been more clear. So Medicare is the one that's for older people and disabled people, and Medicaid's for the deserving poor. Messaging. Yeah, there's in my article, I go into this, there's this idea of the American that internationally, of having this huge blinding white smile with all the teeth perfectly lined up. It's almost a joke. And we sort of laugh at English people for having bad teeth. I don't know if you guys have seen that in culture, the American smile versus that, but it's very classist, right? Who is deserving of having that big white blinding American smile are the upper middle class families, right? That's primarily white people. That's the sort of archetype. And so, yeah, it's aesthetic, it's class signaling. I think that's right. I think there's a lot of missed education about what is required. When I was writing my first article in 2010, I think it was on this, I was really surprised to find out that for families that earn over $100,000 a year, 30% of those kids don't see a dentist in a given year. That I was astonished. I mean, you have to understand, y'all, just to be frank, my grandfather was a dentist. So I was raised, understanding that this was super important. And to him, it was like a godliness and seeing the dentist twice a year thing. It wasn't, a subtle sort of, how parents and grandparents can sort of play a super guilt trip on you. And this was the idea that if you didn't go to the dentist twice a year, you were living in sin kind of thing. So for me, that was really astonishing to see. Yeah, I think there's some education, and there's been some international studies about that, about the role of education in terms of people doing that. There's also a lot of people weirdly overestimate their dental health. They think they have much better dental health than they actually have. And to add to that, a lot of people are terrified of the dentist. They've suffered extraordinary pain going to the dentist, and so they're really scared to go. This is where dental therapists are so good, because they tend to be really well trained in calming people down and building those really good relationships with children. And so again, the outcomes tend to be much better, and the children tend to really enjoy going to see the dentist as opposed to hating it and kicking and screaming. So yeah, all of that is true. It's a really good point. We need to do a better job of messaging in that way. And I agree with you, and I've taken that stance, in my writings about this before. I'm just kind of depressed because of COVID. The way it echoes all of this, I'm starting to wonder if it's an education thing, if it's a financing thing, if it's chipping away or forming these relationships. Do you know what I mean?
Yes, of course. And you really hit a note at home there when you said being afraid of the dentist. I'm terrified that soon I'm going to have to get the wisdom teeth ripped out, and it is scary to go. Maybe this talk has given me hope that I need to go get it checked out. But,
Listen, hold on. With wisdom teeth, do it younger. The younger you do your wisdom teeth, the better.
That's what they told me, and
Yeah,
here I am.
yeah, no, it's true. I did mine at 24, and my face blew up to like this. Thank goodness there weren't smartphones at that time, because my son and his friends, they all record each other coming off of the medication and share that. So I'm glad I didn't have to go through that. Hopefully you won't either.
Fingers crossed. But Professor Blake?
So thank you, Jackie. It's so nice to see your head floating up on the screen.
Hi.
Hello. So you know the history of any time we try to introduce professionals into a discipline that aren't the MD or the, I guess what I'm driving at, I'm curious if we've seen pushback from dentists in the country or dentists abroad about the inclusion of other types of professionals into billing roles. Because I know, that has been such a barrier to getting nurse practitioners and physician's assistants and other kinds of services into the fray, because doctors groups have lobbied against it historically. So do we anticipate seeing barriers like that if we were to try to have more dental therapists?
That's a great question. And hi. I was actually really jealous when Zach was talking about you guys talking at dinner last night. I was like, I miss those dinners so much. And I'm sorry I couldn't be there in person. So yeah, I think actually we're getting through that stage to a large degree. That fight has been going on for most of the last 20 years in this country. So dentists were absolutely fervently opposed to dental therapists, and we're fighting it. And then I want to say tooth and nail, which is a terrible dental pun, but we're fighting it pretty hard and making it very difficult. And then places that had no dentists, like no access at all, with these indigenous populations, were moving toward dental therapists. And then it just gradually started to happen. I think the reason is because, well, it's multiple reasons. We have a ton of dentists who've been retiring. That number, when I was talking about counties that don't have sufficient dental care, that's just going to grow. Like, our dental shortage is not being fixed by enrollment in dental schools at this point, and people are aware of that. And then dentists are realizing they make most of their money with cosmetic work and dental implants and things like that. They've set up a system with dental hygienists performing, you know what I mean? Like they've already striated the care within their offices. And I think they're starting to realize there's room for dental therapists between the dental hygienist and the high level, more cosmetic work that they do to get the cavities filled and things like that. And so they're fitting them into a practice model that's actually really good for them financially, sort of reserving their time. There's enough work so they can reserve their time for the things that actually pay more. I don't know if you all go to the dentist, but think about when you go, how the dental hygienist does the cleaning, then the dentist sort of wanders in and hums and haws at the x-rays and sort of looks in your mouth for a second and then says, okay, see you in 6 months unless something's wrong, right? And if something's wrong, they do a cavity filling, or if something's really wrong, they set you for that other time or make a referral to an expert. What the dental therapist does is they tend to do the cleaning and the cavity repairs all at the same time. And then if there's something bigger than that, a dentist comes in and looks and then makes the arrangements for it. Then if they're working within a dentist's office, some of that profit does extend to the dentist, first of all. But if they're working like in schools and things like that, they generate referrals to dental offices for things that wouldn't otherwise be caught. And they can sort of help make that referral take place, like with Medicaid populations who might have transfer problems and things like that. And so what dentists are finding is that it's actually useful. They are useful within an office, and they're useful within the population in terms of generating referrals for things where dentists actually can help, whereas the person might not have seen a dentist in the first place. Do you see what I mean? To get that diagnosis. It's been an education process. The federal government stepping up in 2018 was a big boost. And then there was also this accreditation process. So there's this group that does accreditation for dental schools, and they came up with national accreditation standards in 2015 for dental therapy programs. And that was a big boost too, because that dental schools started thinking about that as an income stream, that they could train these dental therapists, and that started helping as well. So there's been a lot. This is good news. I mean, I didn't mean to come to y'all so dark. There is good news since I wrote my first article, certainly calling for dental therapists. We've moved a lot more in that direction. I don't think it's the same problem as we had with nurse practitioners and physician's assistants and midwives in terms of the huge fight that we've had over the years with lots of licensing and scope and trying to, call them up on criminal charges for practicing outside the scope, things like that. I don't think we're going to see that sort of thing with dental therapists. I think we're moving into a more communal acceptance of them. We'll see though, because it's far less than half the states have any form of dental therapist. I'd love to see it in South Carolina, by the way, it's just where I'm a professor. I think that it would be so good for this state. It would be so good. There's parts of the community that would do so well with this as a kind of job, where it's hard for people with a certain degree of education to move into these quasi-professional jobs And I just think it would be so good for them, for smart people who only can go to school for 2 years, who don't need to make a huge amount of money in a lot of these states, in the rural communities where housing isn't that expensive. It's just such a great win-win to me. Like, I would recommend to a lot of people, like going to high school here, for example, go become a dental therapist. It's a great job.
Awesome. Thank you. Are there any more questions for Professor Fox? I have one up front here.
Hi, Professor Fox. Thank you again for doing this talk for us. This is really interesting to me because I've never heard of the concept of a dental therapist. And maybe that is just a product of me, being in West Virginia for virtually my entire life. So is there anything, I'm sure that folks, who are really knowledgeable in healthcare law, know this, but for anyone else that, similar to like an RN program that, obviously getting a BSN is a 4-year thing, but if you have an RN, you can do kind of an accelerated, to get your BSN, that's like an 18-month program. Is there anything kind of like across the country where there are programs maybe that if you're already a dental hygienist, there's really like accelerated learning programs to, get you to a dental therapist or anything similar to that? I could just see that as being a really nice thing, especially for people who, in states like West Virginia, who have never had dental therapy schools, that could just kind of get our already dental hygienists trained in that.
That is a fantastic question. So really, most people haven't heard of dental therapists. And honestly, it's really weird that I'm somewhat obsessed with dental care, like compared to most people in the universe. I think it's weird that everyone else isn't, but I fully understand that it's weird. No, so dental hygienists have been really big in these accelerator programs and in lobbying for them, and they've been very successful. So at this point, I think it's, from high school, it's like 2 or 3 years, I think, till you're practicing. But I think with the dental hygienist, it's like a year and a half, at least from what I've seen from the way they do these programs. And states are very incentivized to help offset the cost of tuition. So yeah, it's definitely a bridge forward for dental hygienists to do that. And a lot of them are very talented. It's weird. The payment scale for dental hygienists varies a tremendous amount, depending on, their bargaining power and the kind of dentist they work for and things like that. And so I think for them, this is a lot more autonomy and very attractive to people who want to move ahead in that way. So yeah, it's a great question. And yes, there are.
Awesome. Any other questions for Professor Fox? I guess lunch is next, Professor Fox. I think that might be what it is. Well, we really appreciate your time, Professor Fox. Everyone give her a round of applause, please.
Well, thank you so much. I'll see you guys on the panel then.
We were happy to have you.
Yes, thank you so much. I want to echo that. We are a little behind on lunch. So if we could just hang out in here for a minute, hang out, talk to each other. That way we're not in the way when it gets here, and we'll get it set up as fast as we can. And we'll be back at about 12:30 with a panel. Thank y'all. Oh, yeah. Also, for our speakers who need to sign like reimbursement paperwork, they're going to come down at about noon in the event center. So if you need to get that taken care of, we'll do that during lunch too. Thank you.
Test, check, 1, 2. Test, check, 1, 2.
when this panel's over, will you take Professor Buck to the bar? He just needs to get a second.
And David too, does he have stuff there too? More for Professor Moore?
He has the car, so I bet his stuff is in the car.
Oh, of course, yeah, got it. Thank you. Okay.
All right, so 20 minutes. Perfect.
Can you hear us, Professor Fox?
Hi.
Can you hear me?
Yes.
Perfect, perfect. All right. Well,
Sorry to be looming over you all.
I know. I like it. I like it. All right, I'm going to get out of your way. Okay. Thank you.
All right, everyone, welcome back. I am Jessica Hott. I'm a teaching professor and interim associate dean of administration. I'm very pleased to be moderating this panel after such an incredible and informative morning. Thank you all again for coming. Just by way of brief introductions for those of you who may not have been here this morning, we have Professor Zach Buck from the University of Tennessee College of Law, Dean Deborah Farringer from the Belmont University College of Law, and on Zoom we have Professor Jackie Fox from the University of South Carolina School of Law. And each of our guest speakers, clearly for those of you here this morning and reading their articles, have robust backgrounds in health law, and we're very excited to hear them sort of follow up on some of those things they discussed in various aspects of financial considerations surrounding rural health care. And so I really enjoyed all of your presentations this morning, and I'm sort of a burn it down person myself, so I can relate to that. And so sort of just two questions, since we have a little truncated time on the panel. First is sort of the macro question, and then maybe more of the micro question. So we'll start. How do you think each of your areas of research really can be impactful going forward in this post-COVID pandemic, and really making an impact on just the larger problems? I know that's a very big macro question.
Well, I've actually been thinking about this. I don't know if you all can hear me.
Yes, yes, we can.
Yeah. I mean, I think, so I've been working on this article and another one that's coming out in a different law review called The Lived Experience of Health Insurance. And what I'm realizing is that I think I want to work very hard to be a voice for people who are being pushed around right now, like sort of shifting my focus from large scale financing and sort of big justice concerns, which is what I've written about before, to more trying to humanize people and bring their sometimes painful experience back to the center of the discussion, and trying to push this idea of like, what are we attempting to even accomplish with our health insurance and healthcare funding system, right? Like whose needs are supposed to be at the top of the chart. And it's a rough one. It's there are a lot of people who have claimed center stage who have sort of dominated the discussion for a long time with this idea about the role of profit and the need for return on capital investment and things like that. And so sort of trying to pull back from it and saying, I don't want to address that anymore, I think is where I'm coming from. I'd be really curious what you all think about that, though, like where you're coming from on this.
Yeah, so what caught me to this topic was I had been researching telehealth rules as part of the COVID pandemic and the telehealth waivers. And I had an article, my first article, that was just kind of like the basics, like what are the telehealth rules? How will they impact the use of telehealth? What are the pros and cons of some of the waivers on fraud and abuse concerns or other sort of pitfalls? Like we've had all these waivers in place for telehealth and then we've just like blown through them. Why did we have everything in place? And when I was doing that research, one of the things that became apparent, and Zach and I were talking about this last night, was actually that I think that telehealth has the potential to become the next great sort of social disparity between urban and rural, because one of the things that the waivers permitted and drew in was telehealth rules have always been focused on rural health, and the way in which we can utilize telehealth for purposes of benefiting rural health, and therefore it was very limited in the urban market, basically on a sort of only pay basis, no Medicare coverage for telehealth in urban markets, that sort of thing. And it created this, potentially has the potential to create this really terrible disparity between urban and rural markets if we just adopt the waivers wholesale and let telehealth like kind of run wild. And so that was not the first time, but one of the times that I started to focus a little bit more on rural populations and rural health in general, and started to sort of research that disparity that exists, and it kind of launched me into this next piece. And so I guess just on a macro level, just for me, I'm hopeful that we can just focus more on what those disparities are and trying to at least do what we can, like we know there's a gap, to just lessen the widening of the gap if there's anything. Like I have no dreams, hopes that I'm ending it, right? That the gap is closed and like we have solutions for that. But at the same time, like being aware of what might be out there that's actually widening it and further creating those gaps so that we can at least like right now, unless we're going to blow the whole system down, prevent it from just getting even worse.
Yeah, great comments. I think from my perspective, what you've asked goes to the heart of what we do, and that is this tension that we face in health policy that as a scholar, somebody who looks at this stuff, you have to position yourself and you want to think about how can I have maximum input or influence, and how can I remain a persuasive voice while also not just tinkering at the edges. I think that's a real challenge. And the longer I do this job, the more radical I become. And I think there is value in tinkering at the edges. Those are real lives and people's lives that are improved. So when you're arguing about Medicaid expansion or the CHART program or the 5% bump, like that's going to benefit somebody and that's great. But we have a system with a lot of underlying problems, and when you don't look fully at them, it does feel like you're kind of on a fool's errand. I think the concern is if you go too radical, then no one will listen to you. So that's the challenge. I think that's a lot of us have that discussion that work in this field have on different planes, I guess planes and planes, airplanes and planes. But, the thought of like, at what point do you feel like you can boldly make the argument? Like at what point is it your job to move the window, right? To just make the argument, even if you're out there and you don't have anybody really behind you. So I was kind of thinking of the talks this morning, how we were all saying this is all kind of bad news and we're kind of hammering the system, but there's maybe some value in that, right? It's just kind of making people aware of some of the shortcomings. So I think it's a great question. I think the ultimate goal is to try to tie those things together in some way, to try to translate, you have these passions about bringing greater coverage to people or improving rural access. How can you tie that to a regulation or an argument that is perhaps more politically palatable to people or more implementable? And how can you kind of push development? And that's not just our job, that's everybody in this room, your job to do that. So those are, I guess, kind of my thoughts on that question.
Great, no,
Thanks.
thank you. And sort of then the natural follow-up to that would be the micro point about if you could move forward or recommend one actionable intervention to start. And I think you all sort of hinted at some of these. What would one actionable intervention would be your passion intervention if you could push forward, or maybe even consider yourself, Dean Farringer, as you said, advising a board or a nonprofit or other organizations. What would be one intervention in the rural space that could be actionable?
I can start. I think I mean, if we're thinking about the system as it exists today, and so I'm not trying to, go with radical reconstruction, I'm going to say that the last 11 states expand their Medicaid program, right? That I hope that's what they do. That I think that there is ample evidence to prove that it is beneficial to communities, to hospitals, to states, to revenue, to the whole thing. So I hope that, if that's sort of my one action. Big picture, I sort of feel like, I might have a different action step to the extent that I'm thinking about system reconstruction. Because part of what I struggled with in writing this paper and doing this research is that I think the likelihood of my action is slim. So that makes it frustrating. And I didn't also feel like I was able to come up with, under the current structure and framework as we have designed it, things that I felt like were markedly better solutions than what we have now. And it's frustrating to sort of always be coming up with the same thing, to say, like, I'm butting up against the wall. Like, there's no more solutions to be had because of the way in which we've designed the system. But small goals that 11 states expand their Medicaid program, Wisconsin can kind of keep doing what it's doing.
I guess Medicaid expansion is good, and totally restructuring everything is good. So I'm in favor of both. If I had to pick one thing, though, if I was trying to be like one thing we could actually do, it's kind of health adjacent. It would be to get high-speed, reliable internet into the rural communities, and really get that into everyone's homes. Like, if I could, just magic one thing, I think the potential for that to really bring people back into the fold in a big way is really big. You were talking about how we've lost, how you're worried that telemedicine might make the disparities worse. Then I'm thinking, we have people here in South Carolina who got to see a dermatologist for the first time ever because they had an iPhone, right? And they could get on there because we did a big expansion related to education here. We got some federal funds that let a whole ton of people get high-speed internet in their homes so their kids could go to school last year. It was this big explosion of it across rural areas. It's not sustainable the way they did it, but I was thinking that that's something I think might really change things.
Yeah.
And I think it's doable.
Right.
But I think, it would change so many social determinants of health and get people in. I just see a lot of good things that could come out of that.
And to clarify, I would say that I just worry that it's not that it won't take off in urban or in rural communities and help rural communities, and broadband is something that we need to definitely expand. I think it will rocket in the urban communities.
Oh, no, I wasn't saying
and
you
so
were
that's
wrong.
my fear, is that the current gap is this and the next gap will be this. If we let it if we remove the focus of telehealth, historically it has always been for purposes of access in rural communities. And if we remove that as the focus, then that's what I'm worried about, what the impact of that will be.
And especially if, like, all the widgets and things, right? Like, that you can buy for yourself. Like, I have an Apple Watch that I got for Christmas from my family because they knew I would totally dork out on the fact that it tracks my blood oxygenation levels, right? And if we have people in urban areas who have all these things that can be giving feedback all the time with check-ins, I mean, that's going to lead to better management of chronic conditions and things like that. And if you don't have those resources to even just get in on the game, right?
Yeah.
No, I totally agree with you. I just think the potential for it is amazing.
Yeah.
Right, if we were to actually optimize it. I don't think we will, sorry. I think it'd be great if we did.
I have a technocratic and then a hokey answer. So the technocratic answer is to repeal ERISA. I think that's the obligatory health law.
Yes,
That's right.
good answer.
Right,
Yeah,
thank you.
Good answer.
Thank you.
Good answer. Everybody likes that.
That's my walk-off answer.
Drop the mic.
So repeal ERISA, and then states can have a lot more freedom with experimenting in this space for health reform. So ERISA has become a federal cap on states' abilities to be really creative. And I think that's really important in health policy, particularly considering how different our states are. So that's one. And then the hokey answer probably is, I think it's a political problem. I think it's a empathy problem. We talk about, Dean Farringer's talk was so interesting about the disjunct between state legislatures and voter initiatives. And why is that? Right? Like, why is it that the voters want this and yet we're not getting it through our legislature? How do we fix that? Like, if the legislature's not responsive to rural health interests, like, there's some problem there. And I remember also having that same kind of thought about when I first started teaching in Georgia, and there were hospitals that were on the verge of closing, and having this thought that surely people are going to care when their hospitals start closing. Like, surely voters will mobilize, and surely even people who don't live in these areas will care. There was a story at one point in the Atlanta Journal-Constitution about a individual who was in a really bad car accident. She had very bad burns, and the nearest hospital at the time, she was in South Georgia on I-75, and the nearest hospital was in Jacksonville, and she had to take a 2-hour, 3-hour ambulance to get treatment. And I remember thinking, well, surely even people who don't live in rural areas are impacted by rural access problems, and that will be enough of a point of leverage that people will start caring about this. And so I think I know it was like a micro question. I'm like talking about empathy, but that's like a real challenge, I think, when you think about like, how do you get attention on an issue? How do you engage people? How do you give platform and voices to people who are underrepresented? I think that's a real, particularly wicked problem in health policy.
So can I jump in and
Go
sort
ahead.
of respond
Yes.
really
Yes.
quickly?
Sure.
So in South Carolina, in particularly rural areas, in the primaries for state legislature elections, the turnout is so unbelievably low. Like, we have people who take office with like a few hundred people vote for them in the primary in a district that always goes towards one party. It's been one of the most astonishing things to me, like moving from the Northeast down to here with these rural areas. And I wonder how responsive anyone feels, like in the state legislature, to their communities when they're not. Do you get what I'm saying?
Yes.
Like, they're speaking to a very small group of people who actually show up for these things. And I don't know how to change that, but I wonder if the lack of empathy is also just lack of participation in local elections. What do you all think? This is getting super big, right? It's moving way away from health policy, but I mean, almost everyone here wants the Medicaid expansion. They want legalized marijuana, at least for medical things. There's so many things they want. Like, if you look at polling, and a lot of the things our legislature spends a lot of time and effort on are just completely lost on the people who actually live here.
I think this might go back to what I think Dean Reinhardt mentioned yesterday about get involved, right? People in this room, like, get involved, like, donate your time, right, in the areas in which you're passionate, even if it's something small. Because I agree with you. What's interesting is when you think about these voter initiatives, those were, 55-45 in Missouri, for instance, and they were very low turnout elections, right? They were off-year elections. So we're even talking about, even given the small turnout, like, think about if turnout was a lot higher, what those percentages would be, right? So it's kind of a fascinating thing that I didn't expect, that, a direct democracy kind of ballot initiative would be so much more successful in an area like this. But it's exactly like what you said, Jackie. I mean, there are a lot of health policy topics like this that if we put to a vote, I think our policies would shift.
And I got to tell you, one of my former students, so a bunch of my former students are now serving in the state legislature. And I would recommend to all the law students watching this, like, really think about running for office. You can make a huge difference, and you can still practice in most states. It's not like a full-time job. But they are passing really, well, at least they're pushing for very sophisticated health policy initiatives, right? Because they have the knowledge base and they're trying to make that argument. One of my students is pushing the legalized marijuana for medical issues here. And, do that, really think about it. If there's anything you take away from today, it's maybe go run for office.
Yeah. Or feel like your vote counts.
Yes.
I mean, just to end on like a funny note, do people watch Curb Your Enthusiasm? Then, so this season there was They go to vote, Larry stands behind some other guy, and they decide that their votes are going to cancel each other out. Larry's guy loses by just one vote. And if Larry had just voted, so everyone turns around and is mad at Larry, but I think there's that apathy of like, oh, my singular vote won't count. But at some point, each of the votes have to count together, right? Each of them have to count for something. And so hopefully that's another thing we can kind of get over is the apathy of feeling like, or just the feeling of disenfranchisement that like, you know, me singularly, I don't have enough power to sway things. Well, maybe not you singularly, but you collectively with everyone else that are all the other yous. And don't be like Larry, right?
Well, we did shorten our panel a little bit, and I'm sorry that we didn't get to finish this conversation, but thank you all so much for the time that you've put in to contribute to the symposium. We really appreciate it. It was such a pleasure.
Thank you.
Thank you. Bye, guys.
Thank you.
All right, we're going to move right ahead with our next talk. So today, we also are going to be hearing from Professor Valerie Blake, who I think we all know, and Nathan Hammond. So Professor Valerie Blake, of course, is a professor of law here at the College of Law. Her research focuses on intersections between healthcare delivery and ethics, and how increasing state and federal regulation of healthcare financing and delivery will impact chronic disease, health insurance, and professionalism in medicine. And Nathan Hammond, who is also with us, is a graduate of this College of Law. He practices in many areas, including healthcare litigation, and today they are presenting on their paper titled Trans Health in West Virginia. So please welcome Professor Blake and Nathan Hammond. Yeah. Okay. I'm really good at this. Okay, there we go. Does this work? Wonderful. Okay, here's this little.
And bear with us, we're going to bounce between each other a couple times.
All right, so I'm going to get started here and talk a little bit about barriers to healthcare for LGBTQ populations. So LGBTQ populations, naturally, a lot of people would think that people who identify as LGBTQ are more likely to live in urban areas, but what we actually know is about 20% of LGBTQ individuals live in rural areas, and so that amounts to about 3 to 4 million people who actually live in rural areas who are seeking health care and have barriers accessing health care. In general, people who identify as LGBTQ face certain barriers that people who do not identify as LGBTQ might not face. So discrimination is a huge barrier to care and social stigma. Discrimination can be felt, in a variety of ways. There's actual discrimination, and then there's perceived discrimination. So just because someone identifies as transgender and seeks health care may have never been actually discriminated against, but they're more likely to not seek out health care because there's a perceived level of discrimination amongst this population. Additionally, there's a lack of cultural competence among providers generally This can vary. Lack of cultural competence can come in a form of just not asking a patient what their sexual orientation is, what their specialized healthcare needs are. This can increase healthcare disparities among LGBTQ populations, so it's likely to impact people who are homosexual. They may be at an increased risk of sexual concerns and sexual related diseases where that information isn't shared with their provider. The discrimination and social stigma and lack of cultural competency is exacerbated by the remoteness of rural communities, especially Appalachia. The topography of Appalachia is one of the natural barriers to healthcare. A study that was recently done by LGBTQ MAP showed that the majority of healthcare services for LGBTQ populations in Appalachia is concentrated in university towns. I'm from a small rural area of West Virginia, Pocahontas County. It's about an hour and a half to Walmart and 3 hours to Morgantown. So if there's a specialized clinic for care for LGBTQ populations in Morgantown, the person living from my community who's transgender has to drive about 3 hours to receive that care. One thing we know about LGBTQ populations in Appalachia, the poverty is greater. So someone may not even have access to a vehicle. Public transportation isn't widespread in Appalachia. So accessing that specialized care is even more difficult in this region. You can see there's a chart here that shows, who LGBT people are, and transgender in particular, are more likely to avoid care just because of perceived medical discrimination. That's nationally, but it's also exacerbated in these rural regions. Do you have anything you want to add? Okay. So financing issues sort of lend themselves to further barriers to access care in rural regions, and that can present itself in a variety of factors. So what I talked about earlier with, a lack of resources and a lack of designated healthcare facilities. So West Virginia previously was one of 13 states that didn't have a clinic specifically devoted to LGBTQ specialized healthcare or transgender specialized healthcare. Professor Blake told me that is changing. So West Virginia is going to have a clinic that will provide more specialized care in the future, but rural states, especially those in Appalachia, the South, are less likely to have those specialized resources for transgender individuals. Another barrier to care in regards to financing is a lot of these more rural states and Appalachian states will have expressed bans on transgender care and transitioning care in an attempt, allegedly, to save money. We know that banning transition care does not always result in a saving of money, because then that presents issues for transgender individuals and people who are seeking transition care that manifests in other healthcare needs. So it can manifest in depression, it can manifest in needs for other therapies. So then the state is, either having to cover or pay for those therapies, or transgender individuals are paying for those out of pocket. And that sort of, coincides with health harms from untreated gender dysphoria. Transgender individuals who suffer from or who experience gender dysphoria do not necessarily have access to health care as a result of express bans through Medicaid policies and state employee benefit policies. We know that West Virginia, as a state in particular, the state is one of the largest employers within West Virginia. So if you're a person identifying as LGBTQ and you work for the state of West Virginia, your state employee Medicaid or your state employee benefit plan may not necessarily cover the care that you need, especially if you're transgender. If you need hormone therapy, transition surgery, you can't necessarily look toward your state employee benefit plan to provide those services. Additionally, based on the geography and the lack of resources, specialized healthcare is hard to find. You can see here as a map, and this map looks at state employee benefit plans and Medicaid plans. West Virginia and the states in Appalachia in the South generally either expressly preclude coverage for transition and transgender health care, or they have no policy regarding transition or transgender health care. So if you're part of the LGBTQ population in these states, which we know in rural areas is about 3 to 4 million people, and you work for the state or you're on Medicaid, you don't have access to transgender or transition care. This just exacerbates in health disparities. Transgender individuals in rural areas and LGBTQ individuals in rural areas tend to suffer greater depression. They tend to engage in higher risk health behaviors such as smoking, heavy drinking of alcohol. So it's all sort of cyclical. It feeds into each other. We have an increased risk of higher risk health behavior. We have lack of specialized care, lack of access to due to geography, and then a perceived social stigma and discrimination all sort of amounts to this ginormous barrier of care for this population.
Okay, I'm shorter. So, doesn't take much to be taller than me. You know, as Nathan talked about, one of the reasons that we honed in on this topic for this symposium was because of the fact that, you know, there are these tropes about who lives in West Virginia. And I wanted to sort of push back against that and you know, remind readers that you know, West Virginia is a diverse place with lots of different people. And when we drill down into the transgender community in West Virginia and in rural communities, we really are talking about vulnerabilities within vulnerabilities, right? These are communities who count as vulnerable populations, full stop, whether you're talking about urban or rural populations. When you take the intersectionality of rurality and add it to a transgender population, you find that all of the disparities just heighten. When we started doing more research on this topic, you know, I did not know that this trend existed. So I was a little bit surprised to see that you know, it tends to be the case that Appalachia and Midwest and the South tend to have these sorts of de facto bans on access to transition-related medical care. And of course, that is going to be one of the contributing drivers of healthcare disparities for these communities. So what's happening in a district court in West Virginia right now is there's a legal challenge to both the state's Medicaid Act and the state's employee plan. So these individuals we have on the left is a gentleman who's covered by the state's Medicaid plan. And on the right, we have a gentleman who is married to a West Virginia state employee and thus is covered by the state employer plan. And like someone was saying earlier, talking about WVU, I'm like, we are about to talk about the state employer plan, which is my insurance, so I hope they don't come for me. But so let's all just keep it in the room. So these individuals are suing both of those health plans for denial of certain gender identity treatments. So specifically two things that they've been denied. One is hormonal therapies, and the second are bilateral mastectomies, okay? And I want to put a finer point on how the lived experiences of these individuals are because of these refusals of treatment. So transition hormones are not actually that expensive in the realm of healthcare costs. They run somewhere around a couple $100 a month. One of these individuals has been paying out of pocket for these hormonal treatments. The other had to stop when the insurance company wouldn't pay for it because a couple $100 out of pocket a month was just too much, on top of the fact that they were paying healthcare premiums that don't cover these services. So one of these individuals at the time of the lawsuit has had to forego hormonal treatment. Neither of the individuals can afford to pay out of pocket for bilateral mastectomies. And so the consequence of that is that they're both wearing binders for upwards of 16 hours a day, basically all of the time that they're not sleeping. And for those of you who aren't familiar with that, there are medical consequences from that, right? These individuals explain of problems breathing, open sores, a lot of different problems from having to wear a binder throughout the day. The alternative is that they don't wear binders and then they're misgendered. And then it leads to gender dysphoria for them. And then that leads to serious psychological harms. So we really are talking about the ability of people to live in their communities in bodies that they recognize and that others can recognize them for what they are. So this is what's at stake for these individuals. So, and let me put a finer point too on, why a lawsuit against Medicaid and the state employer plan is particularly important. So, as Nathan showed us, there tends to be sort of a trend that Medicaid state plans in rural states are the ones not covering these benefits, and employer plans in those states. Particularly important in West Virginia because of the fact that 1/3 of our population is covered by Medicaid in the state. We have one of the highest Medicaid enrollments in the country. Our state employer plan covers 21% of our population. We're the 4th highest in the nation for the number of people employed by the state. So that's almost half of our population in the state who get benefits from either Medicaid or being a state employee or being married to one, okay? We're not even going to talk about commercial insurance and all of that today. Just those two plans a lawsuit against those two plans could potentially open up these benefits for half of the transgender community in the state. So they're suing based on equal protection, Section 1557 of the Affordable Care Act, and then Medicaid Act's comparability and availability requirements. I'm going to talk about 1557, and I'm trying to see if I have time to rattle on about other things. Let me just say briefly, we have seen some success in other states who've challenged under equal protection claims, particularly states who have expressed civil rights protections based on sex, and particularly where there has been state action that's discriminatory. So there was a recent challenge in Iowa where the state legislature passed a law saying that none of the insurers in the state were permitted to cover transgender care. And the Supreme Court of the state said, yeah, you can't do that. Okay, that's going to be a civil rights violation. And they looked to the civil rights law in the state that protected sex discrimination. We have a little bit of a different set of facts in West Virginia for that. Another angle that you can take is the Medicaid Act's comparability provision. We've seen some success. There's a case in New York called Cruz, where the state Medicaid Act failed to cover gender transition hormones and surgeries. And that court basically said, if you're going to cover these procedures for certain individuals who aren't transgender, you have to cover them for people who are. And so the fact that you provide hormonal treatments for people for other kinds of conditions, the fact that you cover bilateral mastectomies for other conditions means that if you fail to cover it for transgender individuals, you're violating Medicaid's Comparability Act. So, we may seek success for these litigants under some of those umbrellas, but we wanted to focus on Section 1557 because we think it is the most promising provision for a few different reasons. So, Section 1557 of the Affordable Care Act, it's a piece of the Affordable Care Act that didn't get a lot of attention at first. When people think about the ACA, they think about the individual mandate, they think about all of the different kinds of insurance laws that the law addressed, the Medicaid expansion, but kind of hidden deep in the dusty tomes of the Affordable Care Act was this tiny little paragraph that really blew up civil rights in healthcare. So this statute provides for non-discrimination by healthcare entities receiving federal money on the basis of sex, age, disability, and race. And what's most important about this, it's the first time ever that sex discrimination has been banned in healthcare. It wasn't impermissible before. You were totally allowed to discriminate based on sex until the passage of the Affordable Care Act. So they passed the Affordable Care Act. Sex discrimination by recipients of federal funds in healthcare is no longer permitted. And then we're left with this sort of enormous question of what exactly does that mean? What does that look like? And what does that look like for LGBTQ communities who it was less clear whether sex discrimination extended to them or not? So I know this, you're like, ooh, charts, right? It's been a long 2 days. Here we go. Here's another chart with too small a font to even read, even for me up here. So what this is trying to show you is kind of the long trend line of the rulemaking process behind Section 1557. The law passes in 2010. We don't get a rule interpreting this civil rights provision until 2016. The federal regulators were nervous to touch this. It was a complicated beast, and we can talk about why in some ways if we have time. But they promulgate a rule in 2016. And what they basically say is, we're going to interpret sex to include gender identity. And we're going to say in the rule that transgender benefit discriminations, blanket exclusions of transgender benefits, is discriminatory, de facto discriminatory, not permissible. It's a violation of the law. We almost immediately see federal lawsuit challenging that and a nationwide injunction on the provision that said that gender identity was a protected category. The Trump administration comes in 2020, promulgates new rules, and says sex is a binary. It means male, it means female. It doesn't mean gender identity. And we're not going to, do anything if insurance plans or other entities discriminate based on gender identity. And so that's where we have been sitting for a time, and that can explain to some extent why state Medicaid agencies and state employer plans who accept federal money have felt comfortable with continuing to discriminate based on gender identity and continuing to feel comfortable with not offering benefits for these communities, because it was not clear whether or not it was illegal. We had a federal law saying you can't discriminate based on sex, and we had all of this up and down rulemaking and nationwide injunctions that were sort of kicking the ball back and forth about what that actually means with respect to gender identity. So I'm going to kick it over to Nathan to talk about where we're at now with Bostic.
So we had Bostic versus Clayton County, Georgia, and it was a Supreme Court case that dealt with 3 individual employment discrimination cases. And so those came from the 11th, 6th, and 2nd Circuit. And all of those employees claimed that they were either terminated because of their sexual orientation or that they were terminated because of gender stereotypes. So one person identified as transgender. The court, in a shocking sort of analysis, decided that sex under Title VII necessarily included gender identity and gender stereotypes. And so when you look at this opinion, you might think, well, this has to be complicated. You know, how did they come to this determination that sexual orientation and gender stereotypes are the same as sex? But that's not necessarily what they held. They basically did a strict analysis of the plain meaning of the word sex and held that that sex necessarily includes sexual orientation. So if you have a male who's homosexual and you have a female who's heterosexual, but you terminate the male's employment while keeping the female employee just because the male as a homosexual, then that is a termination based on sex, and that is a but-for cause of the termination. So in a roundabout way, they did this really simple analysis and determined that sex included gender orientation and gender stereotypes. So now when under Bostic, when an employer makes any sort of employment decision, whether it be hiring, termination, or some sort of retaliation, and an employee can show that that determination included a determination based on sexual orientation or gender stereotypes, then that employer has violated Title VII. You might be thinking, what does this mean for the Affordable Care Act? Because the Affordable Care Act doesn't necessarily include Title VII. But the Fourth Circuit actually looked to Bostic in deciding a claim brought under Title IX in Grimm. In Grimm, the issue was Grimm was a transgender individual who was attending high school and had identified as male for more than a year and was living as male, but was born as a biological female. And so Grimm sought to use the boys' bathroom, and initially the high school allowed Grimm to use the bathroom for the sex for which he identified as. However, after some concerned school board members sort of started thinking about this, the school board enacted a policy that then students could only use the bathroom based on their biological sex. And so Grimm brought this lawsuit alleging violations of Title IX, and the Fourth Circuit looked to Bostic and held that even though Bostic doesn't expressly answer the question at issue, the reasoning is the same, and that gender orientation and gender stereotypes are included in sex under Title IX. What that means for Fame v. Crouch and other people bringing Section 1557 claims is that Section 1557 expressly includes gender discrimination or sex-based discrimination under Title IX. And so that's how, we get this jump from, even though we have a completely different area of law, it's now incorporated into Section 1557 analysis. And so the Department of Health and Human Services under the Biden administration has actually announced that it will enforce Section 1557 consistent with both the Bostick and the Grimm decisions. And so Grimm being in the Fourth Circuit, Fame v. Crouch pending before the District Court of West Virginia, that will have a direct impact on that lawsuit. Did you want to talk about the anticipated rule?
Right, thank you. Okay, so far we've had a public comment from the Biden administration saying, you know, the dominoes have fallen, the Supreme Court has spoken, Gorsuch, of all people, has spoken, and has decided that sex discrimination necessarily includes gender identity and sexual orientation discrimination. Again, I don't think I thought I'd ever be saying that, but here we are. And so the Biden administration made clear that they, for purposes of their enforcement of Section 1557, read a Title IX ban on sex discrimination to include gender identity and sexual orientation. They are promulgating a rule. We're expecting the proposed rule in April. And I fully expect that in that rule, it will say that sex is defined to include gender identity and sexual orientation. I also fully expect that there will be immediate litigation to try to challenge that. The bright spot in this is that I'm not sure that a legal challenge can land, at least against this question of sex discrimination, because we've had the Supreme Court come out pretty plainly. Gorsuch's reasoning is based on the plain meaning of the word sex. It's not tied to the legislative history of Title VII. It's not tied to anything except for his logical reasoning of what the word sex must mean. And so the word sex must mean the same thing in Title IX as Title VII and Title IX and the Section 1557. So we'll see challenges, but I think ultimately the Biden administration is going to prevail. So what does this mean for rural transgender communities? Bringing it back to this group. So this is a group who for a long time has faced discrimination and challenges with getting access to healthcare in their communities. And litigation like Fane versus Crouch and the movements with Bostick are a real opportunity for federal action to say that state Medicaid agencies cannot blanketly exclude gender identity treatments, and that state employer plans cannot blanket exclude gender identity treatments moving forward. And I anticipate that we're going to see federal courts making that plain, and hopefully we will see Medicaid agencies following along and starting to change their discriminatory policies. What that doesn't solve is the fact that transgender communities face lack of access to providers. And so even if you have the benefits now, you don't necessarily have providers who are trained and capable of offering you these highly specialized services. What we're hoping is a sort of Kevin Costner, if you build it, they will come type of, are you all too young for that reference? No, you aren't. And it was Kevin Costner, right? Yeah, it was. Okay. A Kevin Costner type of thing, right? If you build it, they will come. Once you reimburse for things, providers become a little more invested at providing them, right? So, you know, if you have Medicaid across rural Appalachia saying that they will now pay for gender transition surgeries, pay for hormonal treatments, if you have state employer plans now being forced to do that, you know, and healthcare providers now know that, you know, then that's at least one barrier knocked down to these providers moving into these communities to offer these services. As Nathan mentioned earlier, I just got a call at the end of last week from a doctor at WVU Medicine. They're just now opening up a transgender clinic for adults and pediatrics, and they wanted some law and policy help with what they're fully anticipating will be a lot of dicey issues that they come up against. But we are finally going to have a specialized center in Morgantown dedicated to this issue. And I'll leave you with a powerful quote that I came across when I was preparing for this talk, that had to do with, I think this was actually a person in Texas commenting on the same issue of rural transgender benefit bans. And what the individual said was, it's not that transgender individuals and LGBTQ individuals, they're not eager to flee these communities, right? They have connections to home, land, language, and heritage that are all powerful and all keep them rooted in these communities. But for these individuals, they truly are facing the question of stay in the place they call home or be in the body that they recognize as themselves. And hopefully this litigation is going to allow that to stay beside each other. So we'll wrap there and we'll take questions if we have time.
Yeah. I also think both of those mics are on, if it's over here. If
Okay.
It's easier. All right, do we have questions? I knew it was you. I knew it was going to be you.
So this might be just a teeny bit off topic, and not for it to be a pop quiz, but earlier this week with the Texas governor's sort of statements on that sort of gender affirming care for children could be prosecuted possibly as child abuse. We've seen sort of, not that I can think of something off the top of my head, but we've seen scenarios where other states have sort of come out with really kind of crazy sort of things like this, and the West Virginia legislature has attempted to sort of also adopt that. Do you see any possibility for that kind of an issue taking hold anywhere, or sort of even moving to here and maybe even speaking to its future in Texas?
Yeah. I worry that's a blueprint that we're going to see recreated around the country. And it concerns me greatly that healthcare providers are getting pulled into this. So Governor Abbott, he said that it was child abuse for the parents to get transgender children treatment for gender dysphoria. And he also said it was child abuse for healthcare providers to provide it. Even though, the healthcare community is in wide agreement that gender dysphoria treatment is necessary for minors, and they have a pretty clear set of guidelines of what's appropriate and what is not typically appropriate. We have also seen state initiatives to try to pull the licenses or try to criminalize transgender treatment by physicians. Here's my sort of response to it to some extent. Now that we have a federal law banning healthcare discrimination on the basis of sex, and we have a Supreme Court opinion that says that includes gender identity, what are the consequences if you violate Section 1557? The worst consequence is that you can have your Medicare money pulled, right? Okay, that's the hook. That's always the hook, right? We've talked about this in the last 2 days. How do we regulate healthcare entities? It's typically they take federal money and then we make them accept certain conditions. So Section 1557 says if you take federal money, you can't discriminate, and you can't discriminate based on sex. So that law doesn't reach necessarily state legislatures who are discriminating, but it does reach the healthcare providers and the hospitals and the health insurers who operate in that state, who survive predominantly based on federal money, Medicare and Medicaid. And so you know, we've also talked about how hospitals tend to get their way and they tend to lobby. This is one of those things where the healthcare communities need to go to the legislature and explain that if the federal government wants to come knocking and say, you are violating federal law by following state law, and we can take your federal money away for doing it, that the federal law has the ability to do that. So I think we need some robust federal enforcement, or at least threats. And I think we need healthcare providers to start to lobby and explain to these state legislatures that they're putting the livelihoods of healthcare workers and they're putting the healthcare of the community at risk if these people are put in the position of not being able to follow federal law. It was a long-winded answer, I'm sorry.
Thank you. No, that was a great answer. And also, thank you both for this presentation and the paper. It's fantastic.
Any other questions?
Thank you both. So my question, we've talked a lot about both the dual roles of education and advocacy. How can we as law students both participate in the education and advocacy elements here?
I mean, as a rural West Virginian, you know, they're really, in the area that I grew up in, there is not a lot of knowledge. So even just spreading, you know, word of mouth, getting out there, communicating what resources are available to someone who might not know is going to be a huge help, I think, in West Virginia, where access to resources is so scarce. You have a lot more power than you think as students. People will listen to you. You're the next wave of what's coming. So be involved in organizations, whatever that means, whether it's a law school organization, whether it's you get out and you're a member of your local bar organization. The West Virginia State Bar right now is considering an LGBTQ subcommittee of the West Virginia State Bar. So these issues are more important now than ever, and the opportunities are there. So just take advantage, and if there's a subset that you think doesn't exist that needs attention, then start it yourself.
I would add, so we should all give Nathan a hand. He just accepted a position at WVU's hospital in the general counsel's office, so that's exciting.
Thank you.
And so you are what? How many years out of graduation?
Almost 3, almost 4.
You're aging me. So I tell, right, so you don't get the general counsel job right out, but 3 years, right? And then you get it. And, you know, there's such an important role for compliance too, right? So, you know, if you work with small entities, if you end up working in general counsel, there's such an opportunity to shape this in terms of compliance of those entities. You know, making plain to the people in charge that you have to follow these laws, and then coming up with helpful ways to make that possible, to help people understand what their role is in supporting this is really important. There's been a lot of litigation under 1557 that has had to do with healthcare providers. I don't think at the passage of this law that people quite understood that some of the things that they were doing ordinarily in their clinical practice could be seen as discriminatory. So things like calling an individual by the wrong gender. Those are the kinds of things that hospitals and healthcare providers are getting sued for now that wouldn't have been a cause of action, 10 years ago. So, there's an important role to be played at your level in coming up with the kind of rules and guidelines to help people comply with these laws on the ground.
I think we're going to go ahead and cut off questions there because I know we have people traveling and we want to get you guys home on time. And I know Kate's going to give some closing remarks, but I just want to say again, thank you both. Thank you to our other professors, Professor Van Nostrand, Professor Farringer, Professor Haxgard. It was so great to have you guys here. And I know I'm a little bit biased, but I think this has been an amazing symposium. It's been wonderful. Thank you all.
Yeah, so I won't keep anyone long either, but I do, want to echo Jalen's thank you, to everyone who has helped, make this possible, especially to Jalen and Jared for doing such an incredible job planning this, as well as, Ken and Lisa, who have done everything with food and technology. I don't know what we're paying them, but there's no way it's enough. And so they're fantastic, and all of our support, with Dean Reinhardt, Dean Hott, Dan Kimball to moderate some of our panels. That's just been fantastic, and we really thank everyone for coming, as well as our law review editors who we've had traveling all over the city and also in Pennsylvania to take people to airports and hotels. And so really want to thank everyone for being involved with this. When we were trying to think about, symposium topics, and Jalen and Jared were speaking with Professor Blake, who's also been incredibly wonderful helping us with this, we wanted something that, even if you weren't necessarily studying this area of law, it was still something that was very meaningful to all of us. And, we all interact with healthcare whether we want to or not. So it's something that, we can all take into what we do, no matter what we study. And, I'm a, crim law kind of person, but this is still, really, really close, to what I really care about. And, I want our speakers to know that, honestly, what we've all talked about, in these past couple of days, really does extend. Not only has it taught everyone in this room, obviously an incredible amount of information, and myself included, but it also really does extend, beyond this. We have been, live streaming all of this, and believe it or not, we really have had people tuning into this live stream. So, that's fantastic. I have students I know who are in, dental school in the state, nursing school in the state, who are, and the osteopathic school in Lewisburg, who are tuning into this, who are, taking this information into what they're doing, as well as, Dean Farringer spoke a little bit about, kind of small hospitals really being community sort of supports for small communities. And I am from a really tiny town in Montgomery, West Virginia. Believe it or not, we have a hospital, Montgomery Hospital, that is still in function. And it kind of serves as an ER, serves as inpatient and outpatient care. And we have a pediatrician's office, there who they do a kids fair every year that provides children with vision checks, hearing checks that are necessary for school. Every single year for the past, I don't even know how long, they've also provided helmets to all the children who can come to the fair in this small town where there aren't these kind of resources. I am a 25-year-old law student who, my mother is my biggest fan as usual. She is the office manager of that pediatrician's office, and she's been tuning in. Hi, Mom, if you're listening. Thanks for watching. But she is taking all of this back to that hospital. And so as much as it's been sort of kind of daunting, and we've talked about a lot of the ways where maybe there aren't really good solutions, I really want everyone to know that this is going to have really practical effects to patients here soon. She's taking all of that to her hospital. They're working on a grant to try to get Medicaid expanded to people who have recently had drops in their incomes because of pregnancy or other issues where maybe they wouldn't have known that they had qualified for Medicaid. And so all of this is genuinely going into use in the immediate future to really help people get care in rural communities. So I really want to thank all of our speakers, and I think just just the evidence that we have this and we have so many brilliant people who are able to speak on this, I really think speaks to the fact that we do have people that care and that are working towards this. And that's fantastic. Even when it feels like everything is a little doom and gloom, it's nice that, just the fact that we're having the symposium, that we're having people speak on these issues is incredible. And so I really want to thank everyone for coming, for tuning in, for all of the help that we've had. I'm sure that I've missed thanking someone, so this is my thank you to anyone that I missed, and we will conclude there. So thank you all again.